Hey, good afternoon, everyone. Again, this is Melanie Mock from Kentucky Hospital Association, and thank you so much for joining our Day for Infection Preventionists today. Just a little housekeeping before we get started with our presentations today. We are going to mute all lines when our presenters start. So if you would like to ask a question during their presentation, please use the chat box. We will open lines at the end of the presentation for questions, and then we will mute all lines again. And we do this because we are recording the call today so that it can be on our website later for those who weren't able to join us to view the presentations by our great speakers today. We will also have a copy of the slide deck for all of our presenters after the call today. For continuing education credits, you must stay on the conference for the entire duration, and then we will send you a link to the survey and sign in so that you can get credit for your continuing education. At this time, I am going to turn it over into presentation mode. If you're having any technical issues, please let me know by emailing me directly at mmoch@kyha.com.
Presentation mode is now enabled.
At this time, we are in presentation mode. So again, if you have any questions, you can email me or put them in the chat box. I'm going to turn it over to our host and moderator for today, Deb Campbell.
Thank you, Melanie. And let me first add my welcome to Melanie's. We're really happy to have so many of you able to join us today for what I think is going to be a great conference. First, I want to thank our sponsors today, Trinity Guardian, Soteria Bed Barrier, and Nozen, and we'll learn a little bit more about them as we go through the program today. So we'll go ahead and get started, and I'd like to introduce my colleague here at KHA, Pam Kirchum, who is Director of Hospital Services, and she is going to be kind enough to introduce our first speaker. Pam?
Yes, thank you, Deb. And it's my privilege to introduce you to our first presenters, who are both with Mako Medical Laboratories. In the next hour, you will benefit from a COVID-19 testing update. You'll hear about the different types of testing available, the sensitivity and specificity as it relates to COVID-19 tests, and which tests are appropriate and when. At KHA, we know that timely testing is key to addressing the pandemic and ensuring your patients and staff are safe. Earlier this spring, when many of the country's large laboratories were overrun and not able to meet our hospital's testing needs, KHA sourced and vetted a full-service reference lab to secure the capacity our hospital labs were in dire need of. We found such a partner in Mako Medical Laboratories. Mako quickly stepped up and committed to a 24 to 36-hour turnaround time when many reference labs' turnaround time was lagging between 7 and 10 days or longer. We've heard from the state that the free gravity tests are coming to an end, and Mako offers discounted pricing to Kentucky's hospitals. With Mako, our members can count on faster results, greater reliability, a reserve testing capacity set aside for Kentucky, and 100% transparency with pricing that is less than the CMS rate. With now, it's my pleasure to turn things over to Matthew Tugwell and Steve Hoover with Mako, who are both lab experts and operational leaders. Gentlemen, thank you for your time, and the floor is now yours.
Oh, thank you very much. So yes, this is Matthew Tugwell. I'm the director of the genomics lab here at Mako Medical, and I oversee all the COVID-19 testing. Steve Hoover is the vice president of lab production here at Mako, and he's with me here as well. So I'd like to start off kind of just giving a little bit of background and kind of explaining the magnitude at which we're operating right now. So I've been with Mako for about 5 years now, and we currently process 40 to 50,000 samples per day. And we operate 24/7 with 3 shifts of 50 scientists, and we're hiring an additional 25 per shift as we speak. We utilize Thermo Fisher's testing platform, and we have 34 biological safety cabinets where the samples are handled, 26 Kingfishers, which are automated RNA extraction instruments, and 16 QuantStudio 12K Flex instruments, which perform the qPCR. And our facility is the greatest single location in the country for processing COVID-19 samples. And by that I don't mean we're processing the most samples in any lab, but we're doing the most samples at any one single location, which is our facility here in Henderson. So if we go to the objective slide, during this presentation, we will go over the different types of COVID-19 testing, sensitivity and specificity of these tests, and which tests to use and when you should use them. So next slide is SARS-CoV-2 qPCR. For our COVID-19 qPCR-based testing, we use the TaqPath COVID-19 combo kit from Thermo Fisher, and it includes an internal control as well as 3 viral gene targets that are used to detect the presence of the virus. We use Kingfishers, which are for automated RNA extraction from nasal swabs and UTM, BTM, or 0.45% saline. And the QuantStudio 12K Flexes are for the qPCR and detection. The sensitivity of our assay is approximately one viral copy per microliter. So very sensitive, and the assay itself is specific for its intended targets. The target sequences have been specific only to COVID-19 based on all the available genomes and has been checked extensively for cross-reactivity against other common respiratory organisms. The test is appropriate for asymptomatic or symptomatic people. Someone who thinks that they might have been exposed or have symptoms, then this is the test that is ordered and covers most of those types of cases. So next slide is SARS-CoV-2 IgG test. The IgG tests are performed on DiaSorin's Liaison XL instrument, which utilizes electrochemiluminescence to detect virus from nasal swabs as well. The specificity of the IgG test is 98%, and then the sensitivity varies depending on how long the person has had the infection. The sensitivity of the test is 44% at less than 5 days, 89.9% at 6 to 14 days, and 97.56 at greater than 15 days post-infection. The IgG test should only be used after a positive COVID-19 antigen test or qPCR test was achieved to determine the presence of antibodies. So the next slide, CoFlu-19. CoFlu-19 is our combination assay, which detects the presence of COVID-19, flu A, and flu B, all in one test. It goes through the same workflow as our COVID-19 qPCR test, except it utilizes a different assay for the qPCR piece of the workflow. Samples are collected the same way as COVID-19 samples are and can be nasal or oral swabs suspended in UTM, BTM, or 0.45% saline. CoFlu is very important, especially now as flu season is upon us, because it can identify the source of infection in symptomatic individuals and provide a clear treatment plan for physicians. Whether the patient has COVID-19 or flu will directly guide that treatment. Again, the sensitivity of our assay is approximately one viral copy per microliter, and the assay itself is highly specific for its intended target. The limit of detection is the same as sensitivity, so that's one viral copy per microliter. Turnaround time right now is less than 48 hours from receipt in the lab, but we're getting most of those results out within 24 hours. And the test is appropriate for symptomatic individuals to determine, whether they have COVID-19 or flu. Test is not recommended for mass asymptomatic screening. If you have, there won't be any, asymptomatic flu cases out there. So next slide, we'll go over our respiratory panel. So the respiratory panel is run on the same instrumentation as COVID-19 testing, and it would be comparable to BioFire or QIAstat respiratory panel, if you're familiar with those instruments, but covers all the common organisms: parainfluenza, influenza, coronavirus, a couple bacterial targets, things of that nature. The test is currently still being validated. We haven't gone live with that. I'm supposed to be wrapping that up this week. The goal is to get that live before Thanksgiving. So I don't have exact numbers on the specificity and the sensitivity, but it should be on par with all of our other testing. So we're expecting it to be highly sensitive and specific. The test is probably best ordered when a patient has symptoms and it has been determined that the patient does not have COVID-19 or flu, to identify the source of that illness and help to guide treatment. It's important to note that the respiratory panel will not include COVID-19 targets, so it should only be ordered after that has been eliminated as a possibility. It does, however, include flu targets. So that's all I wanted to go over. So thank you for your time, and I'm very pleased to have the opportunity to present you all with our testing capabilities here at Mako Medical.
Matthew, thank you so much for sharing your expertise with this audience of infection preventionists across the state of Kentucky. We have many nurse leaders on the line. We have risk managers. We have quality experts and so forth. And so we really greatly appreciate you sharing with us some facets about COVID-19 testing that maybe our lab supply chain professionals know very intimately, and of course they do, but perhaps us in the trenches and more on the front lines don't have that level of understanding. So we do thank you for that time. We would love to entertain questions from this audience. And with that, I'm going to allow Deb Campbell to look in the chat room, see what types of questions we have out there. And, perhaps all of us, too, will have some questions for you. But with that, I'll hand things over to Deb.
Awesome.
Thank you, Pam. I know the first thing that I got on my phone, actually, not in the chat box, was could you talk a little bit about specificity and sensitivity kind of definitionally and what that means to us as far as different kinds of tests? Why do we care about that in one case more than we do in another use of the test? Could you talk about that a little bit?
Sure. Sensitivity and specificity, are two different things, really. Sensitivity refers more to, what the limit of detection is going to be. So that basically boils down to, the minimum amount of virus that we can detect and still call it positive. Anything past that, we're not able to say, definitively if it was just an artifact of amplification or, some other issue. So that's why sensitivity is important. And we're definitely, all the other testing that's being done, there wouldn't be anything more sensitive than what we're doing. We're definitely at the industry standard. Specificity, also very important. Especially when you're talking about a virus that is novel and new. and that is probably, mutating as we speak. So the way that they design these assays is they take every, possible known genome sequence that is available for humans, virus, fungus, any kind of DNA sequence that's publicly available that has been characterized. And then they design the targets so that they're only unique to the novel coronavirus. And based on that, they should only amplify when in the presence of that particular virus. And that sensitivity and specificity, go hand in hand with, preventing false positives, false negatives. So that's why it's so important to have a highly specific assay as well as a highly sensitive assay.
Okay, thank you, Matthew. So just to expand on that a little further, so we know that some of the testing, first of all, clearly KHA would not be partnering and recommending this as a test to be used for diagnosis and identifying sick patients and other kinds of tests. We know it's the gold standard. But of course, as you know, there are a lot of tests out there that have varying sensitivity and specificity, and because of the maybe kind of somewhat at least limited quantity of tests that are available to everyone, that we are being encouraged in some situations to use these tests that have less, what would you say, accurate profile, perhaps. And so I know that all of us have been seeing guidance come out that really have recommended that, the rapid antigen test not be used for asymptomatic patients. And we have heard that, but yet they're still being encouraged to be used for surveillance, which obviously if you're using them for surveillance, then you're testing some asymptomatic patients. So,
right.
As a person that gets asked a lot, so that seems contradictory, and it certainly does. Do you have any kind of words of wisdom about that?
I think it really kind of, you gotta take everything, any type of testing, as is. The problem is there's really no kind of, absolute perfect test, right? I mean, that would be ideal, where you had a test that, always gave you the right answer. And unfortunately, that's not how, molecular testing works. I mean, there's a lot of different, factors that go into, what provides a good result. I don't think there's any, non-value from these, point of care or rapid testing. I think they definitely serve a purpose. I mean, I think they're relatively inexpensive in comparison to other types of testing, and it definitely serves a purpose. But it has to be used in the right context. And I think that's why it's so important to understand, what type of testing that you're getting. And you can use that to kind of, frame it so that you're using the results appropriately. I mean, because the difference in, sensitivity of qPCR-based tests like we're doing, it's not going to miss any positive results. That's how sensitive it is. But the point-of-care, antigen-based testing, they are going to miss some of the cases just because they're not as sensitive. If you catch somebody that's in a beginning stage of infection, their viral load is very high. Those are the types of things that it could miss. So I would just make sure that you always understand what type of testing you're getting and what its limitations and advantages and disadvantages are.
great. And then one other thing you might, I don't see any questions just yet in the chat. You might want to talk a little bit about the fact that we know the CDC has recommended a non-testing strategy for clearing, basically, to use a short-term, kind of a shortcut term, patients. And the reason for that, of course, is that we know that the PCR test is in fact so sensitive that sometimes when, I guess basically live virus that can transmit the illness is no longer present and the person is no longer infectious, but will still pick up pieces of the genetic material. So do you want to talk to that for the folks that are on the call?
Oh yeah, no, I think that's a great point to bring up. And if you had asked me the same question a couple months ago, I wouldn't have really had a good answer for you. But recently we've had some positive cases for people that were on my team, people that had gotten exposed wherever and tested positive. So our protocol was to separate those people from the working environment, and then we were testing them regularly, to see if they would turn up negative, and then say, okay, they're negative, but could you come back to work? They don't have symptoms, and that approach had worked for a while, but we had 3 cases where people just continually tested positive. This was 2-3 weeks after the initial inspection, and a week after they had any symptoms, and they were still coming up positive. And they're what we're referring to as long haulers. They're carrying residual virus that either is dead or not affecting them negatively, and they're most likely not shedding it either. So what we did to kind of make sure, because we want these people back working, right? We can't have people out indefinitely just because they test positive. So what we did in that case was we ran the IgG and IgM test on these individuals, and the IgG is for testing to see if you've been exposed to it and have antibodies for it, and then the IgM is to see if you have an active infection. And when we tested these individuals on that platform from their blood, we found that they had very low, basically non-existent IgMs. So whatever we were picking up on the qPCR side was just residual and kind of left over, not an active infection. So we've spoken with our medical director here too about the same subject, and I think the CDC is providing good guidance there in terms of if you've been 14 days post infection, you don't have any symptoms, you may or may not test positive with a qPCR based test. But I think it should be. I think that's a good strategy.
Thanks. Despite the fact that I think probably most of the people on this call are aware, and you gave a good explanation of why, that we should not be doing that, we do know that there are still folks out there who are recommending, people like to test until they're basically negative before they allow them to do certain activities or return to work, or even sometimes transferring patients from one facility to another. Do you have a I know I have a couple of resources to help with that. Do you have anything you would recommend that people could go to or to read to help with the understanding of the fact that that's probably not the best way to manage the situation? Do you have anything you'd recommend?
I think the CDC is probably the best resource to go to in that situation. I don't have anything off the top of my head except that anecdotal story that I told you. I mean that's a firsthand experience of an example where continual testing isn't necessarily the best way to clear somebody and say they're safe
Okay, that's helpful. Thank you. Does anybody else have any questions?
I have another question for Matthew. This again is Pam. I know right now with, the flu upon us, there are some COVID-19 tests that can do a fuller panel. I believe that you all might have one test with 3 results that you can detect influenza A, influenza B. Is that something, can you speak to that? Is it more expensive for a provider to order that? Is it something that you're seeing that more of our hospitals are starting to order a fuller panel? And is it as, effective with all the sensitivity and so forth?
Yeah, sure. No, I can absolutely speak to that a little bit more. So I did the validation of the COVID-19 flu A, flu B combination assay, and we validated that panel with COVID-19 samples that we tested with our other platform, and there's a complete agreement between the way that those 2 assays function. So there's it's just as accurate as detecting COVID as our just standalone COVID-19 testing is concerned. And what's really awesome about it is we built the infrastructure, all the equipment, qPCRs, biosafety hoods. We built that infrastructure to support COVID-19 testing. But the best part about it is all we have to do is just change the assay on the qPCR side, and we can run the COVID flu assay. So in terms of cost, pricing, it's basically the same. I mean, it goes through the exact same workflow as the COVID-19 testing. And that's why it's such a benefit to be able to offer that. A, because we don't have to get a whole bunch of new equipment just to run a different assay, and B, it's not very disruptive to our current workflow because it's basically the same. In terms of which people are ordering that test, we have some states that are ordering it, some universities, but we're processing 40 to 50,000 COVID samples per day, and we're doing about maybe 1,000 co-flu samples currently per day. So it's definitely not on the scale of just the straight COVID-19 testing, but I think that will change dramatically once we start to see positive flu A and flu B cases. Out of all the tests we've run so far, we haven't seen any positives yet. But I think once we start, reporting those out, and people, are suspicious that, flu is out there, I think it's going to be, instrumental in making those decisions about, how to treat people effectively. Because if somebody has symptoms and they're sick without any kind of testing, you don't know if it's COVID or the flu, since the diseases are so similar.
Very true, Matthew. And Teresa has put in the chat, she's talking about patients who are kind of ending their symptom-based or their exposure or symptom-based time period and would theoretically be able to come out of isolation, but they have respiratory symptoms. And of course, she correctly says we have to isolate them. And, I would say that we would have done that anyway, because, the respiratory symptoms could be, as I think she's intimating, could be flu, could be adenovirus, could be anything. And so I think it's easy to get kind of COVID focused. I may go so far as to say it's hard not to be to feel so COVID focused, but I think we would hopefully do what we would normally do if we never heard of COVID, and if people have respiratory symptoms until we know what it is or until their symptoms abate, we have to have them in isolation. And just the fact the quantity of patients that we've had and the lengths of time that we've had people in isolation is of course extremely burdensome. So we all would like to have a magic test that would let us flip that switch, but of course that's kind of impossible. I know your respiratory panels have more than just flu and COVID, though, correct? So there is some opportunity for identifying some of these other respiratory viruses, right?
Oh yeah, absolutely. And like I said, I'm in the process of validating that, getting all the documentation together, getting it signed off by the medical director, putting in SOPs and, dedicating personnel to that. And we hope to go live with that before Thanksgiving. So that is coming up very soon, and we'll be able to offer that. Yeah.
We've all been using viral respiratory panels, for years. So the addition, this is more, correct me if I'm wrong, but kind of just adding the SARS-CoV into that, correct?
Yeah, the respiratory panel does not include SARS at the moment, and that's a manufacturer thing. They just haven't made that particular plate which we run the samples on yet. But that's definitely coming down the works, and once that's available, we'll be able to offer it. But right now, it's just all the other respiratory pathogens. And I think there's about 34 on the panel that we use. So it's quite extensive.
Okay, great. Thank you. Does anybody else have any more questions for Matthew?
One question. I know, Matthew, you can't look into the future to know what is down the pike, but, I know that we all remember, a couple months ago when some of our labs had some of the equipment, but then they lacked the swabs or they lacked the agents to test. And, it was so frustrating for our lab directors because if they had the supply, they could, turn out the tests themselves. Where are we right now, you all as an industry, on the pieces of all of this to be able to, have ample to fill the demand and so forth?
Oh yeah, no, I mean that's a great question and very pertinent point to make. Our supply chains that we have established for testing materials, swabs, tubes, UTM, BTM, saline, all the sample collection devices is very strong. I don't know exactly how many we send out a day, but we're providing these test kits on a regular basis. And like I said, our supply chain is very strong on that end. I mean, we're not projecting or foreseeing any issues in terms of being able to provide that. And the same thing goes on the reagent testing side. We've been lucky enough to partner with Thermo Fisher, and we're very high, if not the highest, on their list in terms of supplying reagents for testing, as well as keeping the instruments running. So we have zero concerns about being able to run the test. Our major concern right now is getting more staff so we can run more tests. We got plenty of instrumentation and reagents, and we also keep a contingency plan in-house. I think we stay stocked up with at least 3 months worth of testing in-house, so on site. If there are any disruptions to supply chain or whatever might happen, then we have at least a little bit of a buffer to not get caught unprepared.
Okay, that's great. I do not see any more questions in the chat. Did I just hear someone?
One thing I was going to ask, I think that it sets you all apart a little bit from the other large reference labs across the country, is you all have a portal that people can go to, whether you're an individual getting a COVID-19 test or whether you're a provider that is partnering with MACo to ensure that tests come back in a timely manner and so forth. Can you speak to that portal and what's, how it's used for the consumer as well as the provider?
I think it definitely adds a lot of value, like you said. I mean, it's real convenient to be able to log in somewhere and have all of your results in one place. You know, we have a great IT programming LIMS, you know, department that built all of these things for us and maintain them, and they really do, you know, provide results quickly. You know, that's not my area of expertise, but it definitely adds a lot of value.
And the portal is free, correct? Like if MACo is doing some type of working with the health department, say in West Virginia, I know you all work with a lot of health departments there, and you're providing the testing, then, you know, the consumer could get the information to access the portal to get their results very fast.
Yeah. It's completely free. I mean, we've interfaced with quite a few different states, you know, through HL7 reporting. I mean, we have to report things to states and in the areas that we do testing just to help them keep track of the numbers. Yeah, and all that in the portal integration, that's all included when we get a client set up.
Thanks, Matthew.
Mm-hmm.
Yes, thanks, Matthew. We appreciate your being with us today. Thank you. And I think we will go ahead and move forward. I wanted to share with you that we want to thank Jansen Galler of Galler Medical for supporting our next speaker. He has been a longtime colleague of ours and a great sponsor for many of our educational offerings that we've had in the past, and we really appreciate him coming through for us and bringing us great speakers like the one that we're going to have today. So I'd like to introduce Gwen Borlaug. She is a nationally recognized infection prevention consultant. From April through September 2020, Gwen assisted the Washington and Texas state health departments with COVID-19 readiness and response for their long-term care facilities. She has been an infection preventionist for 22 years and obtained her certification in infection control in 2002. She received an APIC Heroes of Infection Prevention Award and a Chapter Leadership Award in 2010 and became an APIC Fellow in 2019. So we want to welcome her here today to talk to us about the intersection of bacterial infections with COVID-19 and influenza. Gwen?
Yes, thank you. Can you hear me okay?
Yes, you sound great.
Great. Okay. Well, thank you so much for inviting me to your special day today. And of course, it wouldn't be a day for IPs if we don't continue our talk about COVID-19. And as was mentioned, my focus today is on understanding secondary bacterial infections that some patients with COVID-19 or influenza infections develop during their illness. And then we're going to explore the possibility of using staphylococcal decolonization strategies to help mitigate risk of these secondary bacterial infections among this patient population. I have one disclosure, and that is I am a member of the Global Life Technologies Speakers Bureau. So our learning objective for today is that we're going to describe how the secondary bacterial infections impact patients with respiratory viral infections such as COVID-19 and influenza. Then we'll describe the interactions among the influenza virus, the nasal microbiome, and Staphylococcus aureus, which is quite fascinating. We're going to identify nasal and skin decolonization as a potential strategy to mitigate risk of MSSA and MRSA secondary infections associated with respiratory viral infections. And finally, we're going to list the benefits of universal and house-wide nasal and skin decolonization for hospital patients. And these are the topics we'll be discussing today. We'll start by characterizing secondary bacterial infections, or SBIs, with a review of the prevalence, impact, pathogenesis, and causative agents of these infections. There are two categories of bacterial infections associated with respiratory viral infections. Bacterial co-infections are those occurring at the same time as the onset of the respiratory viral infection, and they're considered community acquired because patients present with them as they come into the hospital. SBIs are bacterial infections occurring after the onset of respiratory viral infections, or may even occur as the patient is recovering from the initial viral infection. SBIs are considered healthcare-associated infections among hospitalized patients because they were not present on admission. They developed subsequently. SBIs most frequently manifest as pneumonia or bloodstream infections and are associated with increased severity of illness, use of healthcare resources, and mortality. We also need to define what we mean by these various terms. So using these definitions from the International Society for Infectious Diseases, hospital-acquired pneumonia, or HAP, is one that occurs 48 hours or more after admission, and the patient, again, had no signs or symptoms indicating incubation at the time of admission. Ventilator-associated pneumonia, or VAP, is a type of HAP that occurs 48 hours or more after a patient has been intubated. Healthcare-associated pneumonia, unlike hospital-acquired pneumonia, is present at the time of admission, but it occurs among patients with certain exposures to healthcare that you see listed on this slide. And then the CDC provides surveillance definitions for ventilator-associated events, which includes ventilator-associated conditions, infection-related ventilator-associated complications, and possible ventilator-associated pneumonia. All of these have very complex criteria. Anybody who's done surveillance knows that, and that just really underscores the difficulty in both diagnosing and categorizing these events. Now, we're just beginning to understand the role of SBIs in outcomes among COVID-19 patients. But early reports underscore the importance of early detection and treatment of SBIs because they do appear to increase morbidity and mortality. Among the small number of isolates recovered during these studies, the two most prevalent organisms, Staph aureus and Streptococcus pneumoniae. Now, these data that you see here come from a meta-analysis conducted by researchers at the University of Toronto. Their aim was to determine the proportion of COVID-19 patients with either co-infections or secondary bacterial infections, and then compare that proportion to the percent of patients who received antibiotics. Their initial data showed only 3.5% and 14.3% respectively of COVID-19 patients had either co-infections or secondary bacterial infections. But you see that almost 72% of COVID-19 patients received antibiotics. And of course, the concern here is that overprescribing of antibiotics is going to drive further emergence of antibiotic-resistant organisms. Now, this is a living review, and data and studies are being added in real time. You can go in on this website and check. I just did that this morning. It hasn't been updated, but it is updated quarterly. So as of the end of October, 38 studies have been included in this meta-analysis. The percent of COVID-19 patients with co-infections and SBIs has increased to 4.9% and 16% respectively. So this is a study to keep watching, and just keep checking this website to help inform prudent antibiotic prescribing practices, as well as an awareness of the potential for co- and secondary bacterial infections among COVID-19 patients. So although SBIs are well-described phenomena following influenza infections, Data are still emerging regarding the prevalence among COVID-19 patients. Providers have faced some challenges in determining prevalence as they strive to avoid exposure from aerosol-generating sample collection procedures, especially during the PPE shortages. And depending on the specimen collected, it can be difficult to differentiate between infection and colonization status. So all of these factors contribute to the low reporting of the causative agents and certainly the under-reporting of SBI. So these are considerations we need to take into account when we're looking at these data. A group of infectious disease physicians in the UK determined that COPD was a comorbidity in severe COVID-19 patients, likely because their respiratory tracts are pretty much chronically colonized with bacterial pathogens. And what are the sources of these bacterial pathogens? First of all, their own endogenous flora, but also the hospital environment with extensive exposure because of long lengths of stay and use of mechanical ventilation. Plenty of opportunity for them to be exposed to those pathogens. How does all of this impact management of COVID-19 patients? In this article, a group of Chinese intensivists recommend COVID-19 patients be closely monitored for signs of SBI, especially among critically ill patients. Why? Because both the long course of the disease and the immunosuppressive state of the patient create high risk for these SBIs. They further state that although data are sparse from COVID-19 patients, we know from influenza pandemics that SBIs are common among ICU patients in particular. So it's reasonable to assume that SBIs do have appreciable incidence during the current pandemic, and vigilance is certainly warranted. Now, as we said, we do know much more regarding SBIs among influenza patients. We have a lot of experience with patients with 5 to 20% of the U.S. population infected every year and resulting in an estimated 23 to 61,000 deaths. Pneumonia is a well-established complication, and among influenza patients with pneumonia, SBI is confirmed as the cause among most of them. Influenza and pneumonia rank 8th in overall cause of death in this country. And as we discussed earlier with COVID-19 infections, SBI increases the likelihood of hospitalization, severe illness, and higher mortality among influenza patients. The same bacterial culprits are at play here, the same as we saw with the COVID-19 associated SBIs. It's helpful and informative to take a look at the data regarding SBIs during the 1918 and 1957 influenza pandemics. Most people who died succumbed to SBIs, and most of it was pneumonia. And staphylococcal organisms were the leading cause of the pneumonia. These two influenza pandemics, the 1968 and the 2009 pandemics, further demonstrate the impact of SBIs on influenza morbidity and mortality. During the 1968 pandemic, it was the elderly who were most affected by these SBIs and by secondary bacterial pneumonia. But during the 2009 pandemic, it was flipped. Children were the group most affected. And strep pneumoniae and Staph aureus continued to be the most frequently isolated organisms from patients with SBIs following these influenza infections. What did we learn from the 2002 SARS outbreak and the 2012 MERS outbreaks? SBIs occurred among 30% of SARS patients, and MRSA was the most prevalent pathogen isolated. Because mortality among MERS cases was so high at about 34%, the incidence and impact of SBIs following those infections really is still unclear. All right, So we've established that SBIs are not infrequent complications of respiratory viral infections, and they do negatively impact patient outcomes. One of the primary risk factors for acquiring SBI is bacterial colonization. Let's look at the upper respiratory tract. This is host to a diverse microbiota, within which a number of bacterial opportunistic organisms exist. And Staph aureus is one of those organisms that's predominant in the upper respiratory tract. And we know it can act as a harmless commensal. It can sit on our skin, sit on our respiratory tract, nothing happens. But it can turn into a highly invasive and deadly pathogen given the right circumstances. The main reservoir for staph in the upper respiratory tract, the anterior nares. This colonization of the upper respiratory tract is a precursor to development of invasive bacterial infections, including SBIs following respiratory viral infections. These bacteria progress from the harmless commensals they usually are to being invasive pathogens. And it turns out they are aided by the viruses that are causing the primary illness. What are these mechanisms by which this transition occurs? Well, one is that the influenza virus and other respiratory viruses actually help enhance the growth of the bacteria and allow them to invade the lower respiratory tract. At the same time, the respiratory viruses then alter the host defenses to bacterial invasion in a number of ways. The viruses alter the host mucosal immunity, leading to failure to control bacterial replication, so it just overgrows, those bacteria grow. Viral enzymes destroy the mucosal glycoproteins, and mainly the ones that inhibit bacterial attachment to the cells. Mucosal ciliary clearance is reduced. And as viruses change the surface membrane receptors, bacteria can more readily adhere to cells in the respiratory tract. So we see how these viruses, as being present in the upper respiratory tract, put patients at risk of SBIs by favoring the bacterial growth and adherence to cells. Now let's look at some of the pathogens specifically. Streptococcus pneumoniae, that's the most prevalent cause of SBIs. It's associated with high mortality and morbidity during influenza epidemics and pandemics. It's the leading cause of community-associated invasive disease worldwide. In this country, 4 million strep pneumoniae infections and 22,000 deaths occur annually. But the good news is the pneumococcal vaccine has cut strep pneumonia infections among influenza patients almost in half. So getting the pneumococcal vaccine is a very effective SBI risk mitigation strategy. The second leading cause of SBI is Staph aureus, which causes serious invasive infections among ICU patients. We all know that. Nasal colonization is a risk factor for development of healthcare-associated staphylococcal infections. Now, most of the U.S. population is either persistently or intermittently colonized, which is a significant risk factor for co-infection or SBI following respiratory viral infections. There's no current vaccine against Staph aureus we can use, unlike with strep pneumoniae. Now, during the 1999 influenza season, the emerging USA 300 strain of MRSA caused several cases of necrotizing pneumonia among children. And children and young adults were the groups hardest hit during this influenza season because of this intersection between that emerging pretty nasty strain of MRSA and the influenza season.
Gwen, sorry for interrupting. Could you speak just a little bit louder? We have some folks in there having difficulty hearing you.
Okay, is that a little bit better?
That's much better, thanks.
Okay. Why is nasal carriage of Staph aureus a significant risk factor for SBIs? Well, this is a really intriguing article from investigators in Ireland that explains, at least in part, some of the interactive signaling that occurs between the influenza virus and Staph aureus. It's called interkingdom signaling. And in general, what happens is, as a body fights the influenza infection, antibacterial immune response factors decrease, resulting in lower clearance of Staph aureus in the nares. So we see at the same time the virus is allowing further replication of Staph aureus, it results the body cannot clear it as well as if it weren't infected with influenza. So at the same time, the composition of the nasal microbiome changes. Again, the bioburden of Staph aureus increases in the nose and lungs. And then the influenza virus emits molecules such as ATP, glucose, and norepinephrine. And that signals to the staph organisms to release themselves from this cozy biofilm that they were living in and go down lower into the lower respiratory tract. All of this sets up the host to develop SBIs such as pneumonia and bloodstream infections. And the underlying risk factor for all of this is nasal carriage of Staph aureus, which is a potential target then for risk mitigation. So now let's explore strategies that can potentially mitigate risk of SBIs among patients with respiratory viral infections. We'll discuss current staphylococcal decolonization strategies, current recommendations, and then we'll consider decolonization as a way to reduce risk of SBIs. Well, first and foremost, of course, is preventing respiratory viral infections in the first place. And for influenza, that means administration of the influenza vaccine. Everyone over the age of 6 months who's got no contraindications should receive this vaccine because it remains the most effective means of reducing severe illness and hospitalizations caused by influenza. We also have vaccines to help prevent those invasive SBIs caused by strep pneumonia and Haemophilus influenza. Those are great risk mitigation strategies. Additionally, we have antivirals that play an important role in reducing severe influenza illness. And eventually, looks like we're going to have a SARS-CoV-2 vaccine that will also hopefully be an effective risk mitigation component in the battle against this pandemic. But for individuals who do acquire respiratory viral illnesses, mitigation of SBI risk caused by organisms for which there is no vaccine entails targeting the colonization state for reasons we just discussed. Nasal carriage of Staph aureus is a significant risk factor for SBIs. The patient's own flora is an important endogenous source, but also these SBIs, again, can be acquired as the organisms are transmitted to patients from the hospital environment. Now, we have several major studies that have demonstrated that nasal and skin decolonization reduces the incidence of certain healthcare-associated infections caused by Staph aureus. And those include surgical site infections, hospital-onset bacteremia, central line-associated bloodstream infections, ICU-associated infections, and more. And as we've seen, nasal carriage sets up influenza patients and possibly COVID-19 patients to acquire these SBIs. So this is the question. Can nasal decolonization be used as a supplemental risk mitigation strategy to prevent staphylococcal SBIs such as pneumonia? If we examine the pathogenesis of secondary bacterial pneumonia, I think that's going to help provide us some insights to help answer that question. The primary cause of hospital and healthcare-associated pneumonias is microaspirations of contaminated nasal or oropharyngeal secretions into the lungs. Everyone occasionally microaspirates, and older adults do so more often. Usually that's not a problem, but it can be for immunocompromised persons, for example, those with respiratory viral infections. So it seems reasonable to trial staphylococcal decolonization as a way to help prevent these secondary bacterial pneumonias, as well as the ventilator-associated pneumonia, because some of those can be caused by aspiration of the nasal oral pharyngeal secretions, in addition to gastric contents. So another source, and so that would get to the endogenous sources. Another source of these bacterial infections, of course, and thus a component of the pathogenesis, is the healthcare environment. That can be transmitted to patients via the hands and clothing of healthcare personnel. And staph decolonization as a means of source control is a known strategy for reducing transmission and subsequent healthcare-associated infections. We know this from studies regarding other healthcare-associated infections, as we mentioned earlier. And as we explore this strategy for hospital patients, maybe we should also consider it for COVID-19 positive residents that are housed in COVID units in skilled nursing facilities. So those of you out there who are practicing those kinds of settings, this question is for you. They are at risk of SBIs. And I often thought about this as I toured many COVID units when I was working for the Washington State Health Department and the Texas State Health Department, looking at them and saying, so often these COVID positive residents, they're housed in semi-private rooms in the units, and healthcare personnel are wearing the same gowns from resident to resident because they need to conserve those gowns. And so we have a perfect setup, I think, for increasing transmission of staphylococcal and other multi-drug resistant organisms. So it might be prudent to apply staphylococcal decolonization strategies, similar to what is done in the acute care setting, to help prevent transmission and subsequent increased risk of staphylococcal and MDRO infections among this vulnerable group. So I think it's something to consider for this specific situation in long-term settings. And again, for those of you working in those kinds of facilities, think about this as we move forward through the presentation. And you can see, looking at this slide, this just depicts what happened in the 2002 SARS coronavirus outbreak, where transmission episodes in this particular hospital in Hong Kong increased by several fold, because even though they were practicing infection prevention measures, there were certain issues with PPE and other, as they were housing patients in wards, where they did have a lot of increased transmission. So it just makes the point that in the current situation and pandemic, we do have a kind of a perfect setup to increase MDROs. Universal nasal and skin decolonization is an evidence-based strategy for reducing incidence of hospital onset Staph aureus infection. And by universal, we mean instead of screening for MRSA colonization, all patients in a given population are decolonized. So we don't have to find out if they're positive or not. We just decolonize everybody, say everybody in the ICU. So we're going to describe this process, and then we're going to review several studies demonstrating the benefits. And as we do, I think we'll see the rationale for at least hypothesizing that this regimen might also help mitigate SBI risk among COVID-19 and influenza-affected patients. Now, this is the landmark study. This was published during 2013 in the New England Journal of Medicine. That paved the way for a more practical, more effective way to address the risk that nasal staphylococcal colonization poses for ICU and other patient populations. Dr. Susan Wang and her colleagues conducted this cluster randomized multi-center trial in which 74 adult ICUs throughout the HCA healthcare system were randomized to 3 groups. So in group 1, the ICUs screened patients for MRSA colonization on admission and then they placed the positive patients on contact precautions. The group 2 ICUs screened all admits and isolated positive patients, but then they decolonized the positive patients with 5 days of mupirocin twice daily and daily CHG bathing. The third group of ICUs did not conduct any screening. Instead, they universally applied the decolonization regimen to all the patients in their ICU. And what did the investigators conclude? They said that the universal decolonization was more effective than the other two protocols in reducing rates of MRSA clinical isolates and bloodstream infections caused by any pathogen. And here are the data. Significant reductions in MRSA clinical cultures, significant reductions in the incidence of MRSA BSI and incidence of BSA caused by any pathogen using that universal decolonization approach. And by preventing approximately 23 BSIs annually, a cost savings of more than $400,000 just in treatment costs was realized. Not to mention, this cost of rescreening was also saved. But there was one catch, and that was that mupirocin, which is an antibiotic, of course, was the nasal decolonizing agent. And the concern was that widespread application would lead to further emergence of mupirocin-resistant strains of staph. And so the authors of the article and several other guidelines and articles you see here, they all recommend developing some type of method for determining levels of mupirocin resistance if you're going to use a universal decolonizing agent, if you're going to use mupirocin. So use of mupirocin then reduces the practicality of the universal decolonizing regimen that Wang was seeking if you have to worry about monitoring mupirocin resistance. The development of nasal antiseptics, both the alcohol-based and the povidone iodine-based products, have solved the issue of emerging antibiotic resistance. They are non-inferior to mupirocin in their activity against staphylococcal organisms, but they do have several benefits compared to mupirocin. They don't promote antimicrobial resistance. If you think about it, alcohol and povidone iodine and CHG also, they've been used in healthcare for decades, yet organisms remain widely susceptible to these agents. Antiseptics are effective after the first dose. Mupirocin takes a few days to become bactericidal. Regarding how easy these agents are to use, I don't know if any of you have ever talked to surgical patients about their experiences with mupirocin, but I've talked to several surgeons who have talked to their patients, and what did they find? Lots of negative responses from their patients. And why is that? Because that ointment accumulates in the nose after a dose or two. Many patients end up then just simply rubbing it around the outside of their nostrils, and of course that is ineffective. The alcohol-based nasal antiseptics are formulated specifically for twice-daily decolonization regimens so that they won't irritate the skin with prolonged use. And because the antiseptics work immediately, they can be applied on the day of surgery, and so we don't have to worry about patient compliance with 5 days of mupirocin. Then that's a big deal. That's a very much improves the quality of that pre-op surgical bundle. So as facilities are now embracing this innovative approach that is practical, effective, economic, I want to provide several examples of success stories from facilities that are practicing universal decolonization. This first one is from UHS, where the incidence of MRSA bloodstream infections was already very low. They were at 0.08 BSIs per 1,000 patient days, because what they were doing is they were screening their high-risk patients and they were placing them in contact precautions. And so that was working very well for them. But they were looking for an easier and more economic way to keep these rates low. So they decided to implement universal nasal and skin, that's CHG bathing, decolonization, and then they eliminated contact precautions. And they were able to maintain those low MRSA bacteremia rates at 0.09 per 1,000 patient days after the intervention. They reduced their contact precaution days by 91%, and they realized a cost savings of over $54,000 in just a 3-month period. So that was very successful. The UHS study was just recently published in the American Journal of Infection Control, and the authors state that both mupirocin and povidone iodine were unpleasant for their patients, but the alcohol nasal antiseptic was accepted by them. And again, the conclusion was that universal decolonization with the alcohol-based nasal antiseptic and CHG bathing instead of contact precautions significantly reduced their isolation costs with no increase in MRSA bacteremia. And staff preferred the alcohol antiseptic over the mupirocin. And I just want to point out, it's noteworthy that this was an independent study. There was no financial support or provision of product from any company. This is a study published in AJIC by Mullen and her colleagues from Baylor Medical Center in Arlington, Texas. This describes a trial of pre-surgical nasal and skin decolonization among their spine surgery patients. Now, they had already been doing the CHG bathing or cleansing preoperatively, but they added immediate pre-surgical application of an alcohol-based nasal antiseptic to that. And they then continued that bathing and decolonization in the nares for a few days after surgery to mimic the mupirocin, because mupirocin has an effect even after the last dose for a few days. So they wanted to mimic that. And what happened here is they reduced their incidence of surgical site infection by 81%, from 1.76 to 0.33%. So that was very successful. I just want to point out also in this study, they did also decolonize their perioperative staff. We don't know of how much this adds to the benefit, how much it added to the reductions, but they felt it was important to do that, and they continue to do that in their regimen. Frederick Memorial Hospital in Maryland, they were using povidone iodine as a nasal decolonizing agent, along with CHG bathing for some of their pre-surgical patients. When they expanded their decolonization regimens to include all patients in the facility, they went house-wide with this. They decided to switch to use of an alcohol-based nasal antiseptic more suitable for twice-daily application. And then they included all surgical patients in the decolonization process. And what happened here? They had a 50% reduction in SSI incidence compared to when they were using the povidone iodine. And I was curious about this. I asked them, well, what might explain the further SSI reduction following the switch from povidone iodine to the alcohol nasal antiseptic, because they're both, effective at decolonizing? Well, they offered two possible reasons. The first is that they did add post-op decolonization at the same time they switched to the alcohol nasal antiseptic, just like the Mullen study showed. They used it post-operatively as well. And then the other variable that might have affected the rate is that there was better acceptance of the alcohol product among their pre-surgical patients. Some patients refused the full dose of the povidone iodine product. So one or both of these variables may have positively impacted the results. We just don't know. This article, just published in the Infection Control and Hospital Epidemiology Journal, describes the significant reductions in incidence of MRSA bacteremia achieved by universal decolonization using an alcohol-based nasal antiseptic among their ICU patients. MRSA bacteremia was reduced from 0.24 per 1,000 patient days to 0, and that was statistically significant. So another great success story using this regimen. So these are just a few real-world examples of the many successful outcomes facilities are experiencing as they apply universal nasal and skin decolonization regimens to their vulnerable patient populations. Well, let's recap some of these key points. The anterior nares, they're the primary sites of Staph aureus caries, which is a precursor to and the primary risk factor for development of subsequent Staph aureus infections. Nasal and skin decolonization is a recognized strategy to reduce healthcare-associated Staph aureus infections. We see that from that really large weighing study. Nasal colonization with Staph aureus does increase the risk of secondary staphylococcal infections among patients with influenza infections and possibly COVID-19 patients as well. And nasal and skin decolonization just might have the potential to reduce the risk of secondary staphylococcal pneumonia. Currently, we don't have clinical evidence, but I think we've laid out the rationale to expect that possibility. So the Huang and other studies have led several organizations to recommend universal staphylococcal decolonization as a risk mitigation strategy. Let's take a quick look at some of these. The CDC issued this guidance during March 2019, and it contains 4 major strategies for preventing Staph aureus bloodstream infections among hospitalized patients. The first is preventing all HAIs by adhering to the specific prevention bundles for each of these HAI types. And for the ones you see listed here, the leading cause of infection is either Staph aureus or coagulase negative staph. This second step represents the most novel component of the recommendations, and this is where CDC identifies certain patient populations to which decolonization methods, which is really source control, should be applied. All ICU patients, non-ICU patients with certain invasive devices, and certain surgical patients should undergo decolonization with intranasal antibiotics or antiseptics, plus the topical CHD bathing or cleansing. So far, those steps were aimed at reducing staph infection risk for the patient who is colonized with staph organisms. But this third step then is protecting inpatients from acquiring MRSA colonization by reducing transmission events. How do we do that in the general ward? Well, for those patients we know are colonized, but we're not going to treat them and we're not going to decolonize them, but they've got indwelling devices, contact precautions are used to keep other patients from acquiring MRSA colonization. It also notes here that the contact precautions should also be used for patients with excessive wound drainage, regardless of their MDRO colonization status. Of course, alternatively, facilities could simply decolonize all patients throughout the facility. And we're going to list the benefits of house-wide decolonization in a minute. Day recommendations for preventing MRSA transmission and infection in acute care settings include the use of universal decolonization among ICU patients when MRSA is not otherwise effectively controlled. And finally, the HRET created an SSI change package in which they included CHD bathing and nasal decolonization with one of these agents as a way to reduce SSI incidence. If you haven't checked out this resource, if you're looking to reduce SSIs, this is a great tool to check out. So implementing universal decolonization, again, meaning decolonizing all patients in a given population without screening, has many benefits. The first, most importantly, it mitigates risk of infection to the colonized patient, and then it also mitigates risk of acquisition to the non-colonized patient in the next room or down the hall. It's more effective than targeted decolonization in reducing HAI infections caused by staph. It costs less to decolonize a patient population at risk than to screen and then place them in contact precautions. It does eliminate the need for contact precautions, and so patients are happier and staff are happier. Decolonization also includes, we're going to decolonize patients with MSSA as well as those with MRSA, and MSSA poses a risk as well of subsequent staph infections. and it provides source control. So it reduces contamination of healthcare personnel hands and the patient environment and equipment. And so we're mitigating risk of transmission to other patients. There are also benefits to, I think we looked at this one. Let's look at the benefits now of house-wide application, and that means that all patients in the facility receive nasal and skin decolonization. Now, this strategy eliminates the need to manage colonized patients with contact precautions in all units. It simplifies and improves compliance with the decolonization protocol. It's much less confusing to staff when they can manage all patients the same way. And cost analyses have shown cost savings when we consider the cost of screening and isolation. That outweighs the cost of the decolonization agents. The cost of treating hospital onset MRSA infections, of course, is also reduced. Both patients and staff do appreciate avoiding the use of contact precautions, and that's going to positively affect the patient survey scores. And finally, as we've been considering, it may be beneficial to those general ward patients with respiratory viral illnesses as a strategy to prevent those SVIs. A significant argument, again, for universal decolonization to be applied house-wide. So I hope that if your facility has now already been exploring the use of nasal and skin decolonization strategies to reduce the threat of staphylococcal colonization and subsequent infection to your patients, that you'll consider doing so. And to help with that, we've got some of these references in addition to the ones that we were listing on the slides as we were going through the presentation. So that concludes the presentation, and I'm happy to take questions if we still have time for them.
We do, Gwen. Thank you. We have time for questions. I don't see any of there now. Please type your questions into the chat box, or we can also open the lines if people would rather do that. Melanie, do you want to open the lines and see if there are any questions before I pose one?
Sure, Deb. Hang on just a second, please.
Presentation mode is now disabled.
At this time, all lines are open. If you are not speaking, please mute yourself by hitting *6 or your mute button on your phone. Please do not put us on hold. Deb, you can go ahead with your question.
Okay, I was going to be polite and see if anybody else chimed in first. Let's see. I don't hear anything. Here's one question has been if Nosen interferes with MP swab for COVID. Gwen, can you speak to that?
That is an excellent question. That is one that I had when we know that we could use a nasal swab. And so that was posed to the company. I did pose that question to them. And they recommend that if you're going to do that, if you're going to apply the Nosen, that you take the COVID swab for testing. You do that before you apply the alcohol-based nasal antiseptic. If it's a ways down the road, let's say midday, you've already done it, then they suggest that you clean out the nose, which I think is recommended anyway. Just clean out the nose, and then maybe go up a little bit farther into the nose and take the sample. It doesn't have to be an NP swab, but just go a little bit farther in and make sure the nose has been cleared out. So any residual alcohol, sanitizer, nasal sanitizer has been cleared out. So that's just to ensure that it's not going to interfere with the testing of COVID. Great question.
Any other questions? Okay, so Gwen, I have a question for you. So I know you've been involved in some of the work with the hospitals that are have used this. Can you talk about if there is anything that any barriers that people have run into just from like kind of getting used to the new process? Any kind of logistical things that might be helpful to people that want to do that to make this transition?
Yeah, there are some things, and of course, this is, it's a multidisciplinary project. It involves several partners, and this is why I do recommend, when you want to present it, when you want to talk about it, certainly do that to like your infection control committee, because there's lots of representation on there, because it might affect your antibiotic stewardship program. Sometimes antibiotic stewardship programs like to screen patients in advance to see if they do have MRSA, so that if they come down with an infection, they might treat empirically with vancomycin. However, if you're going to decolonize, that risk is mitigated. There are also, I know from one hospital, they said to be sure to let people know, their recommendation is,
Oh my God,
decide,
it's 2:30.
I think someone is not on mute. Anyway, one of the hospitals advised, decide where you're going to store all your isolation carts, because now they won't be in the hallways. You're going to have a lot of them stored away, and they ran out of room for storage. So that's something to consider as you do this, because you won't be needing as many isolation carts on the units if you implement this. You're going to cut your isolation days by quite a bit, as you can see from some of those studies. So I guess and of course, just the idea of having to implement a new protocol is something that does take time. I suggest getting your partners, really crucial partners would be your ICU nurses and nurse managers. It's very beneficial for them. This is a very attractive protocol for them because they can reduce the burden of contact precautions in those units. So that's a great place to start, is engage and let them take ownership of this implementation process.
Great, thank you. And please forgive me, I was also doing some logistical things during your presentation. I may have missed it. If I did, forgive me. But I know that there have been some staff, not staff the bugs, staff the people, decolonization programs, and I know that you included a study. Have you been involved personally in hospitals where they have used Nosen for staff decolonization, which I know exists, but I just kind of want to know your experience with it and how accepted that was by the staff, and whether in those instances it was kind of a required thing or whether it was a voluntary thing. I know NICUs are where I had heard of this happening, and I know sometimes it's even been offered to parents. I know that. Have you had experience with that, and how did that go? Were there barriers, that sort of thing?
I've not had experience with hospitals with NICUs per se. I've just read studies where it's was successful and very well accepted. When it comes to staff acceptance, actually there was a study by Lisa Steed and her group. It was actually trialed on the healthcare workers first to look at acceptance and ease of use. And that had great acceptance. And what hospitals are finding is that when they do implement these protocols for their patients, the staff tend to take the products and use them themselves. Even though they're not required to, they feel like they're safer because they work with a lot of patients that have staphylococcal colonization. They feel like it's going to be transmitted to them less frequently if they also do that. And so another recommendation from hospitals who have experience implementing this is to add a little bit more product to your order, because you should allow staff to use it. That's kind of a perk for them. It's like with the alcohol gel, when that came out, we found staff that would take it. And so it's just like plan for that, because they're going to like to use it. They feel it's very pleasant to use, and they feel like they're just a little bit safer. They're not going to take it home to their families. So that's my experience with as far as staff using it. Again, the pre-op patients, the perioperative patients, or staff using it at Baylor, they just felt like, yes, whereas 80% of SSIs caused by staph are caused by the endogenous flora, they're a match to the nasal strains in the patients, at least 20%, and some of that 20%, the source just might be some surgical staff. We know that has happened, that the source for some staff post-op infections has been a surgeon or other perioperative staff. So that was their rationale for that. Again, it's not a solid, hard recommendation because we just don't know what the incremental benefits or the added benefits are that are.
Right. We don't have that. We don't have that data.
Right.
So in our chat box.
Yes, go ahead.
I was just going to say in our chat box, Craig Curtin is saying he can talk about the staff questions. So that would be great. Craig, if you're unmuted, please go ahead. Craig, we cannot hear you. If you've called in on the phone, make sure you unmute your phone. I know Melanie opened the line, so we should be able to hear you if your phone is unmuted. If you did not call in and you're using computer audio, we won't be able to hear you. So if you want to, oh, you're on a desktop computer. Yeah, we won't be able to hear you. You'll have to call in using the call-in number if you want to talk about that. And he said he's going to try. Did I interrupt you in the middle of a sentence, Gwen? I think I did accidentally.
Well, just regarding to that staff, it is just, they really do like it. It's very well accepted. If you look at the SEED study, I think between 90-some% said they would recommend it to their colleagues. And so very well accepted, and then it's very easy for them to apply it to their patients as well. So that's kind of from the staff side, from the healthcare provider side of things. But yes, Craig can answer that more because he works directly with the hospitals. I just have been visiting with some of the IPs, and here's some of their comments post-implementation.
Craig, are you on now? Craig? No, that's not still be on. Okay. I know that I was at a conference where several of us, you know, used it just to see what that experience was, and it was very pleasant. It was certainly nothing. There was no negative to it that I could see. So has a pleasant smell. It doesn't burn or anything. It's pretty something that I would feel like offering to a patient without thinking twice about it. So that's a good thing.
And
Craig, are you on?
And I have.
Nope. Okay. Go ahead, Gwen. Sorry.
I would encourage IPs if they're wanting to focus this on their surgical patients. I would go interview some of them before they go into surgery. Those that have the Mu-Pearson treatment, and just ask them how it went and what they thought about that product. And then maybe offer them a little sample of either povidone iodine or the alcohol-based one, you know, and see if they like that better. The povidone iodine one, again, that is not formulated for twice daily use. So if you want to use that out in the ICU, you're probably better off using the alcohol, because that is that's not going to cause that skin irritation when you have to apply it twice daily the whole time that they're in the ICU or on the general ward. So, but the Mu-Pearson, definitely, I mean, these products, they like them so much better than the Mu-Pearson.
So, guys, can you hear me? I was able to jump.
Yes, we got you now, Craig. Go for it.
Okay. Thank you. Yeah, and I want to disclose I am one of the directors at NOSEN, so there is a little bias coming here. But yes, we have several hospitals that have implemented NOSEN for their staff, and I think one of the questions came up was it derived from the staff or was it administration? In a lot of situations, as Gwen has been saying, it's actually a combination of both. If people that aren't on the call, or people that are on the call that haven't had an opportunity to, try NOSEN, we'd love to get you some samples to show you the way that it works. It's very pleasant for the patient to use. It's very pleasant for the staff to use. And Jansen and myself can get you samples for the people that need it. But it is a pleasant experience. and we'd get really good feedback. In the Baylor study that came out in 2017, I think Gwen referenced, but that came out in AJIC in May of 2017, and they actually, they didn't require the staff to use it, but they certainly, wanted the staff to use it if they would like to, and in their study, in their orthopedic study, they reduced their infections by 81%, and the OR staff did use the product. And they had about a 78-80% compliance rate with their staff. Riverside, California just implemented a program, and they, again, they encourage their staff to use it. Most of their staff does use it. I'm not sure of the compliance rate, and we're going to have to get those numbers back from Riverside, California. But they actually just presented their data at ID Week that we can share with everyone, and it's their use of Nosen. And again, this is with their surgical patients, not with their, there's not a study yet or with their staff using it. But their staff, so far, the data that we've gotten back from Riverside, California, is there hasn't been one nurse in the facility that has gotten COVID since their implementation. And they implemented Nosen to their staff, I want to say back in like early as March. And they do use it, for certain things that we're not allowed to talk about because of the FDA, but and we could also get anybody that's interested in that stuff. We can get them, affiliated with Riverside, and you guys can speak to the Riverside physicians and the nursing staff.
Okay, Craig and Gwen, I have a hospital that's interested in samples. Is there a possibility of that?
Yeah, not a problem at all. Just let us know who that is, and we'll get those out to you ASAP.
Okay, I know this person's contact information very well, so I will connect you after the call.
Yeah, I see Teresa. I think it might be Teresa, but whoever needs them, just please let us know, and we'll get those out to you right away. If there's any information that anybody needs regarding Nosen, Jansen and I are available to talk to you via Zoom, in person, whatever you guys would like.
It's a nice intervention because it covers not just one entity, so disease entity. So that's always good, and no downsides. So great.
Yeah, I mean we have over 900 hospitals. Yeah, we have over 900 hospitals using the product because of what you just said. Because there really is no downside to the product, and it's relatively inexpensive. It's roughly about $2.30 a dose.
It's a lot less expensive than all that PPE.
It is. It is.
Right. Okay, so if anyone else has a question, you can speak up now or put it in the chat. Give you just a few seconds to make sure there are no last-minute questions. Okay, well, thank you very much, Gwen and Craig. We appreciate your time today and appreciate all the great data. And I know your slides are made available. If anyone is continuing to have trouble downloading slides, we will make them available. I know Melanie has put that in the chat, but in case you came on late, we're happy to do that. Everyone has agreed to share their slides, so that will be no problem. So again, thank you too. We really appreciate everything that you've shared with us today. Thank you.
Thank you for the opportunity.
Thank you.
Okay, we'll move. Oh, you're welcome. So we will, we're moving a little bit ahead of schedule. I don't think anybody will complain about that. We'll move on to our next speakers. I'm going to go ahead and do the intro for both of our speakers who are sharing the next hour, but then I'll introduce who's going first here. So we are going to have in the next hour both Dr. Emily Messerly, who is the Immunization Branch Manager in the Division of Epidemiology at the Kentucky Department for Public Health since March 2020. Her career has spanned the inpatient and outpatient settings in pediatric and adult oncology, hospice and palliative care, clinical trials research, school-based health services, and baccalaureate nursing education. She has collaborated with the American Cancer Society, the Kentucky chapter of the AAP, the Foundation for a Healthy Kentucky, as well as the Kentucky Primary Care Association. Most recently, she's collaborated with the University of Kentucky College of Public Health to develop and operationalize a statewide survey assessing Kentuckians' attitudes and beliefs regarding the COVID-19 vaccine in development. She has served as an advisor to both the Healthy at School initiatives with the Kentucky Department for Education, as well as the Healthy at Work initiative with the governor's office. And she's been great to work with. She and I and many others have been working on vaccine allocation and distribution work, and just a very easy person to work with, very knowledgeable. So we look forward to hearing from her after the first speaker, which is Captain Doug Thurlman, who's a career officer of the U.S. Public Health Service, is a U.S. Centers for Disease Control and Prevention career epidemiology field officer who's been assigned to the Kentucky Department for Public Health since August 2002. He subsequently served IHS as their national hepatitis coordinator from 1999 to 2002 when he came to Kentucky to help build public health preparedness and epidemiologic capacity. He has served as the Deputy State Epidemiologist for Kentucky since 2013 and as the Acting State Epidemiologist in 2016 to 17 and from April 2018 to the present. He is currently the Scientific Response Manager for the COVID-19 Incident Command Structure at KDPH, where he is coordinating and overseeing the COVID-19 response. And Doug is perhaps one of the busiest people we know, and in fact, when I asked if he could start a little early, he said he's busy doing things for the governor. So we appreciate Doug taking some time out to talk to us, and such a knowledgeable person and always really generous with his time. So Doug, we appreciate you being here. Please go ahead when you're ready.
Sure. So you can hear me all right?
Yes, sir.
All right, good. So yeah, that governor's press briefing that he does every day at about 4 o'clock, we have to have all the numbers to him by around 3 o'clock so he can be prepared for his talk. And so between 2 and 3, we're usually scrambling like crazy people trying to get all the numbers right, make sure they're correct, and get them to him. And today was my day to do it. I tried to get out of it, but everyone else who does it was busy too. And so I was racing to get those numbers done before I did this talk. So anyway, so I'm happy to be here. Thank you for having me. My title, COVID-19 in Kentucky Reporting and Surveillance Process, is a little bit of a trick because we've talked to you about that many times on the KHA town halls and things like that. So mostly I'm going to give you an update and then a few slides at the end just talking about some specifics about our reporting and surveillance process. Excuse me, did somebody try and say something? No? All right. All right. So, so do I have control of this slide?
You do at this time, Doug. You can advance your slides by going to the bottom right-hand corner of your screen.
Oh, I see. Okay, cool. All right. So just to give you some background on where we are worldwide right now. So as of Sunday night at 7 o'clock, now we're much higher than that already, but we had 137,586 cases, known cases in Kentucky, and 1,661 deaths. I think we're at 1,697 as of the numbers I just put together for the governor. So we had quite a few. I think we had 33 deaths reported today, but we're at a 1.2% mortality rate, which is actually very good for what's going on across the world. In the United States, there's been 10,846,373 cases, 244,810 deaths as of Sunday night, with a 2.3% mortality rate. And both in Kentucky and the United States, that's basically covering the whole country, all of our area. And then in the world, 53 million cases. So a lot of folks have had COVID, and 1.3 million deaths around the world that we know of, for a 2.4% mortality rate. So it's pretty severe, despite a lot of thought that it's no worse than the flu. We've actually had I would say 4 to 5 times the number of deaths in Kentucky from this in one season than we've had from flu in 4 seasons. So it's 4 to 5 times more deadly, I guess I would say. Okay, so looking at worldwide incidents, there's been it's been a lot in the politics about bad leadership and this and that and the other thing, and I think this virus doesn't really care who the leader is. Europe had an early phase. You see in the green kind of color there, they had an early phase where they surged, and then the United States really surged, and you see we have a big, the orangey color there, we've got a big hump. And that's not just the United States, that's the Americas, so that's South America, North America, Central America all combined, but lots of cases around July, August in that area, and then we kind of tailed off. We're still climbing again dramatically, but you look at Europe, the green color toward the right end of that graph, they have just gone off the charts, so they are really in a critical phase right now with lots of spread. And people have tried different strategies. In Sweden, they tried a strategy of not quarantining and isolating, just letting people, be careful based on their own recognizance. And the Swedish president just announced a couple days ago that was a complete failure, because now they're having more cases than anywhere else in Europe. So it worked for a while, I guess, but it may have just been luck that they didn't have a lot of cases yet. So hang on, there we go. I've got things popping up on my computer that are blocking my card. So here's the epidemic curve from the beginning of the outbreak, January 22, up until the current time in the United States. And you see we're getting close to 200,000 cases a day now at the current phase we're in. That was, again, as of a couple days ago. So that red line on the graph is the 7-day kind of rolling average that is calculated across that, because we get surges in cases based on the day of the week, and on weekends there are fewer cases reported than on weekdays. That's why you see those bumps going up and down. So I just wanted to show this. I may have shown this on an earlier KHA town hall, I don't recall, but this is the most recent version of this. This is looking at deaths in the United States from all causes from January 1, 2017 up to January, oh, well, not January, up till the present time, sorry. And what it shows is you see a cyclical pattern where in the wintertime we get a lot more deaths because of respiratory illnesses, particularly flu. And where you see those, well, the orange line is kind of where they would consider there to be excess deaths if it gets above that. And so you see those plus signs are the times when it gets above what they would expect normal amounts of death. And you see back in January of 2018, we had a surge, and that was due to flu. But now you see since COVID started that we've had excess deaths every single week since then. And so it looks like we're approaching normal at the end, but that's really an illusion, because deaths are slow to get reported. So as more deaths get reported, I think that will change and still be in the plus category due to COVID-19. And it could be there's some excess death due to other people not being able to get medical care or not seeking medical care because they're sheltering in place and things like that. So just to give you a comparison across the United States, you can see Kentucky there is right in the middle as far as their incidence rate. This is incidence per 100,000, and you see the northern Midwest states, North and South Dakota, and those states in there are really having high incidence. Strangely, you look at New York, and it's in the same category. I guess it's maybe one shade darker than Kentucky, but despite their huge numbers in New York City, the whole state as a whole is
the largest health
is bad off as it seemed, and a lot of the rural states are really experiencing higher incidence rates because they have smaller populations, so it affects. They probably have less access to health care and things like that, and so you get a little bit higher incidence in those areas. So this is Kentucky. So this is our epidemic curve, and you can see clear back in March we just had a few cases, and then we got around 1,000 cases a week for 12 to 14 weeks there up until mid-June, and then it climbed, and that's when businesses reopened again. That's when we started letting people mix more, and then so we hovered around 3,700 to 4,000 cases, a little over 4,000 cases for another bunch of weeks, like 12 weeks or so, and then come September, and colleges and universities start to get back in, and schools start to get back in, and people start mixing more. Then you see the real climb, and I think that's the hallmark of COVID is that where the disease is in a population, if you have people gathering, then you're going to start having more spread, because it's kind of a silent spreader. We have some people that are infectious and a portion that are not, and so once you start gathering, you don't know who's infectious and who's not, and the disease passes. So last week we had our highest week ever with 16,000 cases in 1 week, 16,748, and that surpassed the week before by about 4,552. I think it was 12,196 the week before. So we're in an exponential climb right now, and we'll see this today's numbers. I think were 2,900 cases for one day reported today that I just turned in on those numbers I was working on. So it's climbing pretty quickly. This is another example of that. So we do our 7-day average daily incidence rate, which I'll explain in a few minutes here. And the map up in the upper right-hand corner is October 15th. So that was 1 month ago from the date I took this was November 14th. And you can see that you maybe can't read it very well, but our categories there. On track means you're having less than 1 case per 100,000 population on average in the 7-day average daily incidence. Community spread with the yellow counties are 1 to 10 cases per 100,000. Accelerated is greater than 10 to 25 cases per 100,000, and then critical is 25 cases per 100,000 or higher. And the reason we picked those is there's been some work that was done early on in the pandemic about when public health would be facing a crisis because the numbers would be overwhelming, and that can kind of translate to healthcare as well. You know, once we start getting overwhelming numbers, you start seeing the hospitals not having enough bed space, not having enough ventilators, things like that. So back in October, you can see now the color scheme was a little bit different. The dark orange are really the red counties in the current map, but in that upper right-hand corner map, the dark orange counties are the critical ones. So you see we have a big cluster of critical counties out in western Kentucky, and they've been really hit hard. But we still had a smattering of yellow counties and a lot of orange counties and even one green county a month ago. We have had no green counties for several days now, and most days only one or fewer yellow counties. So you can see most of the state now is in the critical phase, and we're really feeling that in public health because we don't have enough people to do the normal public health work that needs to be done to keep up with contact tracing and isolation and all those kind of functions. So this slide's kind of going off the screen a little bit, but what this shows is our test positivity rate. And there's been a lot of publicity about that, about how important the test positivity rate is. What this really shows is out of how many people have been tested, how many are positive. And that's a great measure if you have a consistent amount of testing. So you're doing the same number of tests every day, then that tells you that your disease rates are going up or down. But if you don't have a consistent amount of testing, which we have not over time, then that rate doesn't show you a whole lot. But more recently, it just basically shows if you got enough tests out there. But more recently, you can see that curve on the right-hand end is going up and up and up, and that's because we have a lot of testing going on now, and yet our rates are getting so high that our positivity rate is going up. The reason it was so high back on the left-hand end over there is because we, in the very early stages of the pandemic, we were only testing symptomatic people, and originally only people we thought were likely to be COVID-19 patients, so you get really high positivity rates, and there wasn't a lot of testing available. But about May, we started getting a proliferation of tests available, and in fact, that's been a problem because there's been so many companies that have come online to test that we're having a hard time keeping track of all that. But you can see in the big bold letters up in the upper right-hand corner, yesterday's, or November 14th positivity was 8.95. It was 8.98% yesterday, and today it's 9.10. So we're still climbing as we speak. So a few things I wanted to talk about the actual folks who get COVID-19, or to look at the gender, race, and ethnicity and age distribution, because those are interesting for you to know of. So this is breaking it down by gender, by sex. So you got female and male. And in these next 3 slides, the blue bars are the population of Kentucky, the red bars are cases, and the green bars are deaths. So you can see in the population, the females are about 50.7 and the males about 49.3. But females represent about 53% of cases and males only 46% of cases. And then for deaths, females are about 51.6%, males are about 48.4%. So females are a little overrepresented in that, but that's completely explainable by the fact that women tend to live longer and they tend to be more likely to be in nursing homes, and that's where we see more mortality, because once it gets into nursing homes, sometimes it's difficult to stop the spread, and folks there often have other comorbidities that lead to death. So looking at the racial distribution, there's been a lot of talk about that. You see the white population is about 87.6% of our population, Black African Americans about 8.4%, and then on down from there. Ethnicity, about 3.8% of the Hispanic population is, or of the population is Hispanic. You see in the case proportions, whites are about 82.2% of cases, whereas African Americans are about 10.7%. And you see for Hispanic, there's a big disparity. They're about 8.3% of cases, even though they're only 3.8% of the population. The death is the interesting one. So for white race, the death percent is about 85%. For Black or African Americans, 11.5%. So you see a disparity there where they're only 8.4% of the population, but 11.5% of death. Interestingly, multiple or other races or Asian, their death proportion is actually lower than you'd expect based on the population. And then Hispanic is lower, and that tends to be because we've had a lot of Hispanic folks that have gotten COVID-19 mainly because of work settings, because a lot of the meat packing plants and other factory settings hire Hispanic people. And so we've had a lot of outbreaks in those settings, but they also tend to be younger working age people, so they're less likely to die of COVID. So you have lower mortality in that group. The really striking finding is this with age, which most of you are probably aware of. So if you look at the population, your highest age groups are 0 to 19 and 20 to 39-year-olds with 25.2 and 26.2% of the population. And then it goes down from there, 12.4, 13.4, 12, 7.2, 3.7. So our 80-plus-year-old population is only 3.7% of our population. And then if you look at the case in the red bars, for 0 to 19-year-olds, 15.2%, then the most bulk of our cases right now are 20 to 39-year-olds. And then, once again, it goes down from there. So 80-year-old plus folks are only about 5% of our cases. But then when you look at the mortality ratios, you have very little death in young folks. In fact, the 0 to 19-year-old death, there's only one death in that age group in Kentucky so far, and that is was judged as a COVID-19 death because that was the only finding this infant had, but it may have been a SIDS death. We just don't have any way to know that the child was positive for COVID-19 when they died, but were apparently asymptomatic. But 20 to 39-year-old, we just had a few deaths there, or one or two, I think. And then you go up from there. But look at your 80-plus-year-old. That's 50% of our deaths basically are in the 80-plus. And if you add the 60 and above, that's about 90% of our deaths are 60 or older. That's not to say that older people are the only ones affected, but they are surely affected more than most. And a lot of that's due to comorbidities. A large majority of our cases have other comorbidities, particularly diabetes, obesity, and cardiovascular disease. So they've got a lot of other things going on that can contribute to death. So looking at our current situation here on November 14th, about 6.5% of cases have been hospitalized in that upper right-hand figure. About 1.6% have been in the ICU, and we estimate around 64% have recovered. We base that recovery not just on whether we know they've recovered, because we don't get that information on a lot of people, but basically on whether they've, a number of days after they've had onset of symptoms and there's been no hospitalization or no death reported, then we will eventually count them as covered. So, and then it looks like close to 6% have been healthcare workers. That was actually higher earlier on in the outbreak, but it's gone down a little bit. So healthcare workers tend to be at risk because they're exposed to people more frequently that may have the disease. And this is just to show you where we are as far as death.
Emily, that's right.
Hey, Emily, sounds like you're on. The curve, early on, it's kind of an anomaly because we didn't have that many cases back in April, but we had a lot of deaths. But then it tailed off when we closed down society and kind of everybody sheltered in place. Our case rates went down, our death rates went down, so things were looking much better. But then when businesses started opening up and we started getting more cases, then and I think early on, I think part of that surge was we had a lot of involvement in long-term care facilities. So I think that was a big portion of why there were so many deaths early on. Then in July, August, we started seeing deaths go up as cases went up. We had kind of a little drop off in September, and now the latest surge is the highest. And once again, that right end of the curve is an illusion, because it takes quite a while for deaths to get reported and counted. So that right end of the curve is going to go up quite a bit more than it is probably the last 2 weeks of that. So like 14 days. So that surge is already higher than our previous surges. So we're certainly headed to a much higher number of deaths as the case rates increase. And part of that is because it's so pervasive in our society now that there's just that many more opportunities for it to get into long-term care facilities and affect people there. And just to show you a little bit of that, so this is a chart showing our congregate care impact up to the 14th. So we've had 18,000 cases in congregate care settings that we know of, and that's about 13% of our cases. But we've had 1,057 deaths, which is about 63.8%. In fact, I think we were up to 65% as of yesterday's numbers. So that's climbing once again. That's been 475 congregate care facilities, and 382 of those are long-term care facilities. Of course, that includes jails, other correctional facilities, behavioral health, places like that, group homes. And a lot of staff. So we've had well over 6,000 staff members in those facilities, and 8 deaths among staff members. So it's not just affecting the patients in those places. And here's a graphical representation of that. This is the yellow curve in front shows long-term care settings, non-congregate care settings, and the blue behind is the congregate settings. And you see how the blue really overshadowed originally, and then it's kind of evened out, but still more recently we've had quite a few cases there. So just to relate directly to the hospital population that we're talking about, these next 3 graphs are just simple representations of where we're going as far as inpatient census. So these are COVID-19 patients across the state. You can see since about September 21st or 22nd, we've just been on a steady climb for COVID-19 inpatient census. Here's the ICU census. And so we were hovering around 150, a little less than that. And now we're up to well over 300 ICU beds that are being used for COVID-19 currently. And on the ventilator, you see the same issue. So interestingly enough, in Kentucky, we don't have a shortage of ventilators. We're actually hovering around 30-35% usage of the available ventilators. So we've got a lot of capacity for that. Our ICU beds, we're hovering around 70% usage for all ICU beds, not just COVID-19. So we're closing on kind of a risky area where we've got too many ICU beds used up, and in some regions have already felt that. So let's just talk briefly about some case definition and reporting and surveillance issues. I just wanted to put some general slides here to talk about some of the issues. So one of the main things is if your facility is testing for COVID-19, one main point is symptomatic patients should be isolating until they get results. And I know how difficult that is because sometimes the results take 4 or 5 days, but if the person is symptomatic, they should be staying out of circulation until they get those results and know for sure. All lab results, positive and negative, are reportable to public health. That comes through a variety of ways, but and we'll talk about that. But all positive cases are reportable by the clinician or facility to public health. So we used to have the EPED 200 form and the CDC case investigation form. I'm sure you're all well aware of that we have those 2 forms. Well, now we have one form to report. It's the KDPH COVID-19 case report form, and it is a fillable form, and we keep finding small faults with it and improving it. We've actually got a new version that just should be posted today, and that should be the final version except for one additional modification we're trying to do. So still, you can type that out and fill it out, but it still has to be faxed at this point. But we are working on a solution to actually have a button on the form that once you fill it out electronically, you can push that button and have it submitted electronically rather than having to fax it in. So we just had a call about that this morning. We're trying to get that together and see if we can get that put out in the next few weeks, if we can get that working. So that will be a huge time saver if you don't have to fax things in and work from that angle. So one of the most important things for hospitals is my plea to please fill out and submit the reports as quickly and completely as possible. One of the problems is we often have a lot of missing information, and that delays the investigation, especially if we don't have any good contact information for the patient and if we don't know when their symptoms started and things like that. So that's very important. But in positive patients should be informed to isolate until public health contact them. So one other thing is they should be told to isolate until they get the results, but then it may take public health a while to contact them just because the health departments are overwhelmed right now. So it may be 1 to 3 days before they're contacted, but they need to isolate for at least 10 days in order to avoid exposing other people. So that should be a definite message that goes out there. And if they're still symptomatic at the end of 10 days, if they're still having fever and they're still having pretty severe symptoms, they should keep isolating until they get better. So that's an important message. So how do we define a case? Now I'm going to caveat this that I'm going to give you how we define a case in general terms, not really super specific, and we can give you the specific definition, but it's something to be careful with because in a healthcare setting, it's not as important. This is really for surveillance purposes. For us to count cases, it's not necessarily to tell a patient whether they're a probable or a suspect or a confirmed case, because that generally just confuses people. But in order to count cases, we have to have a case definition, and CDC establishes a standard case definition for all reportable diseases. States can adapt those for their own purposes, and they often change when we learn more about a disease. So like the CDC case definition, for instance, for COVID-19 just changed last month. So we try and follow that COVID-19 CDC case definition with a few minor modifications. We added some specificity to our testing criteria, and we give some additional examples beyond what the CDC definition has. And then we clarified for non-COVID-19 related deaths that if the cause of death is clearly unrelated to COVID-19, this will not qualify despite laboratory evidence of SARS-CoV-2 infection at the time of death. So people are always worried that we're counting COVID-19 deaths that shouldn't count. And in Kentucky, we're very careful about only counting them if the death was caused directly by COVID-19 or it was a contributing cause of death. So for instance, if a person gets in a car wreck and they just happen to be positive for COVID-19 on the autopsy, that is not counted as a COVID-19 death. You know, that it could have been that their symptoms caused them to have the car wreck, but if we don't have any way to know that, then we're not going to count that as a COVID-19 death. So, all right, so there are 4 criteria for the case definition in Kentucky. The clinical criteria, and this is really simplified, it's much more complex. It takes about a page for the true clinical criteria to be written out. It's basically signs and symptoms consistent with COVID-19 and no alternative likely diagnosis. So if the person has upper respiratory symptoms, or they have even GI or loss of taste and smell, or fever and things like that, those kind of meet there's a bunch of them that classify as 2 or more or 1 or more of these symptoms that are listed to classify for the clinical criteria. Then there's laboratory criteria. Not one of these defines the case yet. We have to look at putting it all together. So the laboratory criteria is confirmatory is detection of SARS-CoV-2 RNA. Presumptive laboratory criteria is detection of the antigen, and supportive is the antibodies or the antigen in an autopsy specimen. So that's the way the CDC case definition is broken down. And then for our epidemiologic criteria, those include close contact with a confirmed or a probable case, so we know that there's a definite possibility of exposure, or they're a member of a risk cohort where there's a definite possibility of exposure. For instance, they are in a long-term care facility where there's an ongoing outbreak, or in a jail, or in a school classroom, or someplace where we know there's cases, so there's definitely a risk there, so they're a member of that risk cohort. And the final criteria is the vital records criteria. So if it's listed on the death certificate as a primary or contributing cause of death, that's another thing to consider in deciding whether it's a COVID-19 case or not. So in defining the case of COVID-19, a confirmed case is always PCR positive. That's the one criteria that we depend on. Although there's lots and lots of talk, about people who got a PCR positive and then they went back out a negative the next day, and they had negative antigen tests. So there's a lot of confusion about that. So we really work to assess whether they're truly PCR positive or not, and whether that meets the case definition. For probable, they can meet the clinical, meaning they had signs and symptoms, and epidemiologic criteria, meaning they had a close contact with a confirmed case. and not have any lab evidence at all. Now, we've got very few of those that we've counted, but that can count as a probable case. Presumptive lab criteria, the antigen test positive will qualify as a probable case. And then if they meet supportive lab criteria, like being antibody positive, and they have clinical or epidemiologic criteria, that would count as a probable case. Or if they meet the vital records criteria, but there's no confirmatory lab evidence, if they've been declared as a COVID-19 death, but we don't have lab evidence, that can also meet the probable criteria. And then finally, suspect meets the supportive lab criteria, so they're antibody positive, but they don't have any prior history of being confirmed or being a probable case. So, and then finally, if they meet the clinical and epidemiologic criteria, but they have a negative confirmatory test, that can also be counted as a suspect case. So the only cases that we actually count in Kentucky when we give official numbers are the probable and confirmed. Suspect does not count as a case. That's one that we keep in our logs, but we don't put it in the official case counts. So the case definition for clinical purposes for you folks is really, if you're confirmed or you're probable, that equals you're a case. So that's what we want patients to know, is that they're a case. We recommend not telling patients that they are a probable case, because that just really confuses people and they think, oh, I'm not really a case, I'm just a probable case. So for either one, you're going to follow the same procedures. You're going to instruct them to isolate, and they should have been isolated until the test results were given. And they should do that for 10 days from date of symptom onset, unless their symptoms don't improve, like I was mentioning before. And then we want to identify their close contacts in the healthcare facility if they were exposing people there. The exposure status for healthcare workers is determined by the procedures performed and the PPE worn. And we have a decision tree that we've distributed about that. And if we need to send that again, we'd be happy to. But some healthcare workers are not counted as exposed as long as they're wearing the proper PPE during the appropriate procedures they're doing. Quarantine for healthcare workers is determined by their exposure status. Are they exposed or not? And then their essential worker need for that worker. So we don't recommend working if you should be quarantined if you're exposed, if it can be avoided. Unless there's a critical staffing need and patients are going to die without that person being at work, we recommend they be quarantined. But there's that exception in the CDC guidance that people can work while quarantined, and outside of work, practice all the appropriate prevention measures so they don't transmit to anybody else should they become infectious. So, and for both confirmed and probable, we're going to report the case using the report form, and then follow up with the patient and public health as needed. On the suspect case side, that case is still going to get reported using that case report form. But one thing that's important is to determine the likelihood of infectiousness and follow the above procedure if it's warranted. So in most cases, if it's antibody positive, they're not going to be infectious anymore. They may be, but that's the thing, is if they still have symptoms or they were symptomatic actively when they saw you, then that's someone who may still be infectious, and you want to follow those procedures to get them isolated and things like that. But a lot of people are going to be antibody positive weeks and months after they had the disease, so they aren't likely a risk to anybody else. So we just report the case, and then public health can follow up on it. So I want to go through quickly 3 things, because I had them on the objectives list, is the test positivity and the incidence rate, and I think the mortality rate. We'll get to it here. So test positivity, so that's the percentage of tests that are positive out of all tests performed. And the positivity rate that we produce at KDPH is a 7-day rolling average. This is the maps that are online that they use for whether schools are going to meet or not. And that's that map I showed you that was almost all red. So that's a 7-day rolling average, and it's based on the cumulative tests in the past 7 days. We only include test results from laboratories that are submitting all their positive and all their negative test data electronically. And we don't include them if they're more than 7 days between the specimen collection and the test result date. So we don't get historical data grouped into the current test positivity rate. And we only base it on PCR-based tests. So we're not including antigen and antibody, and that hasn't had a huge effect because PCR is the bulk of the testing that's still going on. And then we deduplicate it. If it's the same person and facility and date and result, then we deduplicate that and only count that one. Sounds like somebody might put us on hold.
Melanie can mute.
Okay.
Yes, I'm going to mute all lines
Baptist
at this
Health
time.
is the only health system. Presentation mode is now enabled.
Okay, can you still hear me?
At this time, you can continue. Yes.
All right, great. So that produces this method of doing it produces a rate very similar to overall aggregate test data. So for a long time, we collected data from all labs about all testing, and it was just aggregate test numbers. So they tell us how many positive antigen, antibody, and PCR tests they had, and how many positive or how many total tests they've done, and they reported that daily. And then we would calculate our positivity rate based on that. Well, we started doing it through this PCR electronic data submission method, and it came out very similar but smoother. It's more stable, and it's much easier to produce because we just have it programmed into the system now. So the basic formula is total number of positive PCR tests in 7 days divided by total number of PCR tests in the past 7 days. And I should have put on there, no, that's it. Times 100 to get your percent, but anyway, so that's the basic formula for our test positivity rate. Our mortality rate, also called our case fatality rate, because really there's a lot of talk in different sectors about mortality. So if you talk about the overall mortality of COVID-19, that would be divided by the whole population. So it's a very small percent. It's like 0.02% or 0.01% or something. But we're really talking about a case fatality rate here. How many people who get COVID-19 die from it? And so that formula is the total number of deaths due to COVID-19 divided by the total number of COVID-19 cases. And so for COVID-19, it has to be a direct cause of death or an indirect or contributing cause of death. And we do have a committee that reviews questionable cases and determines whether they should be counted as a COVID-19 death or not. And that's got several physicians on it and several epidemiologists. So we review the evidence, the nursing notes. So when we call and say, hey, we need notes on this patient that died, that's why, because we're trying to determine if they're a COVID-19 death or not. So that may happen in your facility. And finally, our 7-day average county incidence rate, the 7-day rolling average, is the average of the past 7 days, just like the positivity rate. And so we count up the cumulative number of people counted as cases in the past 7 days, and they have to have a confirmed or probable status reported to the state. That's one of the holdups, so sometimes that status doesn't get updated in the data set, so it doesn't get counted for a few days until that happens. That we exclude cases with an onset date more than 7 days before the report date, just like we do with that positivity rate. We may lag behind county case numbers due to reporting delays and missing data, and we pull the data at 8 o'clock each day, so if things come in after that, they don't get counted until the next day. And we could have too many cases due to duplicated cases not being cleared out yet. So we often get reports through different mechanisms of the same person, and we have to deduplicate that. So sometimes we might have higher numbers than a county just because we haven't been able to deduplicate data yet because there's missing data that we can't figure out if it's a duplicate or not. So the denominator that we use is our census data from 2019 estimates for county level data. So it's the total number of COVID-19 cases over 7 days divided by 7 to get the average, and then divide that by the 2019 county population estimate. So that's what makes that map that we put up every day. And so finally, my last slide is just healthcare really is the front line for public health, and the testing and reporting that you do in the healthcare facility by mainly infection prevention is the one who makes sure this happens. It helps us to identify cases, it gives public health the information needed to take action, and it prevents further transmission both in-house and through public health action. The lab results are essential, the clinical diagnosis, case identification, but the clinical investigation and complete reporting are critical. If we don't, usually the lab results have basic information, but they don't have all the things we need to prosecute the case, to go after contact tracing, isolation, investigation, all that kind of stuff. So that allows public health to take action, and then it reduces further transmission and death because we're doing those things. So that fillable form is something that's really critical. If we can get that in as soon as possible and get that as complete as possible, that really helps us in our efforts. So I do thank you. I know you all are under as much stress as we are trying to deal with all this, and I know you're working really hard at this, but I thank you for all you're doing and encourage you to keep it up because it won't go on forever. We will get through this. It's just at the height right now, and hopefully won't get much worse. So that's all I have, and I just want to thank you, and I'd be happy to take any questions, or if you want to go to Dr. Messerly and have her go next before that, that's fine.
Let's see, does anyone have any questions for Doug before we move on? There might be some specific, might be easier. I have one for sure. Doug, could you knew that, right? You were expecting that.
Yeah.
So, Doug, I have one thing that's come up lately in several different venues and been discussed, and that is the the healthcare worker who is exposed, you know, anywhere, but most of the cases I've been hearing about they've been exposed outside of the workplace, and they go through the same process that everyone else does. They have a contact with the contact tracers and are told that they should quarantine, and then but some workplaces are beginning to tell workers sometimes, well, no, because CDC lets us have you work if we're short-staffed. And the concern that has been raised by quite a few people is that my reading of those CDC recommendations are that it's not just short staffing, that really that we need to be certain and kind of exhaustive in what we are doing to correct the staffing concerns before we pull that trigger. And so some of the things that I saw in the recommendations were, you know, backing off, not necessarily not doing any elective procedures, but you know, backing off on some things that we can do, using staff that aren't typically at the bedside. You know, there were several things mentioned that could be employed before we say we have, quote, critical staffing and we have to do things outside of what the contact tracers and our departments of health are telling us to do. So I tried to frame that the way I heard it from both sides. Can you give us your take on that?
No, that's absolutely the situation. I mean, the bottom line is healthcare facilities are the worst place to have someone who's got COVID-19 working, because they're likely to expose other people who may be vulnerable, and that can lead to severe outcomes, including death. You know, so if there's any way to avoid that, that's what should be done. But we do realize, and CDC realizes, and that's why they put that in there, is that if there is a critical staffing shortage, like I said, if people are going to die because that person can't be there, that's a problem. I mean, it's better to take a risk of COVID-19 than have people dying from other things, you know. So that's the issue. But if you can find other ways to get around it and not have that person come in for their quarantine period, that's the best thing to do. And let me tell you, I'll give you my personal example right now. So my daughter Jocelyn works in a nursing home, and she actually moved out of our house a couple weeks, well, more than a couple weeks, like 3 or 4 weeks ago, in order not to expose us. And she came back to pick some stuff up and gave my wife a hug, and we think that's the exposure that my wife got. So my wife got symptomatic. She got tested. She's recovering, but she of course is in our household, and now we've got 3 of our 4 kids that are here also positive. I'm not positive, but me and my one daughter are not, but that's taken a number of weeks. My wife's now yesterday was her 3rd week since she was tested positive, so it's a little more than 3 weeks since she was positive. So it's been a very slow progression of people getting symptoms and then getting positive. So it's not something that if you get exposed, you're going to show up tomorrow and know you've got symptoms and get tested. It's something that you can be walking around and still be infectious and not even know it, or have very mild symptoms. And so that's what makes it a real risk in the healthcare setting. If you've got people coming in that think, well, I got exposed, but I'm just having a runny nose or whatever, you could be exposing other people. And there's no mask wear that's going to prevent that kind of transmission. It reduces it dramatically, but you can't say there's no exposure, even wearing an N95, because the air coming out of that can expose other people. So it's really recommended, if there's any way to avoid folks coming in, then to do that. But we realize there are situations where that can't happen, you know, because it's going to have higher risks by that person not working. So that's my take on it.
Thank you. I know that it's not simple for hospitals to figure out when they're there. I understand that. I just know that it's come up several times where people are kind of trying to say, well, we're doing that, well, we're not doing that. And I know that, you know, apples could be apples to oranges, but certainly, let's see, Andrea's got something there too. We've had some issues regarding the health department keeping some of our healthcare workers off the guidelines set forth by public health. It states specifically improved in symptoms, not absence of symptoms. Just want some clarification since public health is the law. Oh, okay, this is with someone who's had the illness.
Yeah. Well, so
Okay.
that's I was going to say that's the anomaly with the CDC non-test-based strategy for release from isolation is if you've been a case and you are symptomatic, they say you should go 10 days past the date of onset, and you have to have no fever, without fever-reducing medications, and to have quote-unquote improvement of symptoms. But nobody's identified or defined what improvement of symptoms are. I would say if somebody's still got significant symptoms, that would not be a good indication to go back to work. But if they've had significant improvement, then that's worthy. The likelihood is, and Dr. Spicer can talk to this more diligently than me, but the likelihood that they're still infectious is very low if they've had good improvement of symptoms. They're not having any more fever, and it's been at least 10 days since their onset.
Okay. Makes sense?
Yeah, unfortunately, it's not cut and dried.
Oh, that would make it nice, wouldn't it? Well, and I know that we may, in our hospitals, we may get to these true crisis situations, so it is wonderful that we have some flexibility for that, because obviously we have to have people to take care of sick people. But I think the caution to not use that in a cavalier manner is just
I think one of the solutions to that is at least long-term care facilities. It's really effective. Hospitals a little less or more difficult unless it's within patient population. But one of the solutions to that is people who are COVID-19 positive are the perfect people to work with COVID-19 patients. So if there's people hospitalized for that or in the long-term care facility, they can work with those populations without reserve because they're already positive themselves. So.
Okay. Any other questions? Well, okay. If not, if you have the time to hang out in case people think of questions, that's great. If not, we could forward things to you afterwards.
No, I'll definitely hang around till 4.
Okay, great. Thank you. So, Emily, I don't know if you were on yet, but I gave you a lovely introduction. You talked about how great you were. We will go ahead. Did you miss that?
I was not on when you gave me the introduction because I was logging on to the OnStream Media, and I couldn't do it through Google, so I had to use my old school Internet Explorer. So I was troubleshooting that probably when you were introducing me. So thank you.
Oh, well, I'm sorry you missed that because it was quite the introduction. You know, Emily is wonderful to work with, and I know you all heard all of her bona fides for this work that she's doing with the immunization branch. So, Emily, whenever you're ready, you can go right ahead.
Thank you so much, Deb, and thank you so much for having me today. It's weird to talk to people and not be face-to-face or on camera, but we've all gotten used to that, I'm sure. So yes, as Deb probably introduced me, I am not just a nurse practitioner, but I am a nurse, and I see the name of my predecessor, Christy Royalty. Shout out to her. She's a new infection preventionist, and she was interim immunization branch manager before I started. So wow, didn't she pick a nice time to switch roles? So anyway, what I want to go over with you all is what we're doing at the state level for COVID-19 vaccine planning. And it looks like my slide set says 10/29, and then it says updated 11/9. I actually updated a little bit after that. You know, we have to get commissioner level approval, but things have changed a lot since then, so I'll be talking off the cuff a bit too. So if you all have not seen our actual state plan, and this says here version 1.1, I hope they've updated it. We have a slightly newer version, but online is based on the CDC's, what they call it a playbook. They somehow think that this is a sport, and it's a playbook, but we submitted our state plan, draft plan on the 16th, and then have one more addition to that. And basically what it outlines, you know, what are we doing at the state level to prepare to get this vaccine disseminated out to every
120 counties across our Commonwealth. So we have, one of the things that comes up is, wow, who's paying for this and how are we paying for all of this? Well, we did receive some initial funding from the CDC, and of course it's based on population. Everything that's allocated in public health is based on your population. But going forward, the big operation of getting needles in arms, according to ASTO and AIM is, you all have, I think, APIC is your immunization or your infection prevention organization. Mine is AIM. And then Dr. Stack's organization is ASTO, Association of State and Territorial Health Officers. So our two organizations have gotten together and have written a white paper and have asked for $8.4 billion additional from the federal government for COVID-19 vaccine distribution. And, given that we have just had a, we have a president-elect, not sure exactly what's going to happen with that funding between now and January 20th, but it sure would be nice to see some more funding coming for our statewide planning because we haven't gotten very much so far. So we are really relying heavily on you all at the hospital level and at the health department level to utilize existing infrastructure to get this vaccine out there. So this slide right now is totally outdated because just yesterday, of course, we had the announcement about the Moderna vaccine. Pfizer has their data ready to submit for an EUA. I'm really waiting to hear that any day now.
This conference has been running for a long time. Please press *1 to continue with this conference. Otherwise, your conference will be disconnected in 1 minute. Thank you. Your conference will now continue.
Okay, did everyone else?
Sorry, Emily. Sorry about that interruption. Go ahead.
No worries. They're just saying it's been a long conference call. So an EUA is an emergency use authorization. That doesn't happen very often, but in pandemics it happens all the time. It happened with the remdesivir, the Regeneron, and now we're waiting for that EUA process to happen with this Pfizer product. I'm sure you all have probably looked online. If you haven't, the Pfizer product is challenging. It is, it's going to come in these massive boxes of 975 doses. It has to be kept at ultra-low cold storage. Once it's taken out of that ultra-low cold storage, it's only viable refrigerated for 5 days. And it also has to be reconstituted, and it's a preservative-free vaccine. So all of those things together create all kinds of layers of complication about how do we distribute this, how do we store it, who gets it first. So public health preparedness has done every year. Public health comes up with a pandemic flu plan. So we started out with that pandemic flu plan, and then we've been, tweaking and refining it and changing it and getting updated information from the CDC every day about how to get the pandemic vaccine out. So typically, preparedness uses these entities called pods. It's a point of dispensing, a closed or an open pod. So you all at the hospital level are technically considered a closed pod. And so a closed pod means we've got our own people, we're going to vaccinate our own people, kind of just like you do for the flu vaccine. And hopefully this year you've had a really high uptake of the influenza vaccine. We actually have some data from our registry to show that we've had a really significant increase in flu uptake from 2018 to 2020. So each year we've had significant uptake. So how are you going to get this vaccine from us at the state? So the logistics of this. So a provider can be a hospital, provider can be a pharmacy, a provider can be a clinic. So there is a specific COVID-19 provider agreement. It was created by the Centers for Disease Control and Prevention. They sent it to all programs as a PDF or a fillable PDF. However, because they have really specific reporting requirements, we have to have all of that information in a capturable format. So we have it in a REDCap. This REDCap link is on our KY COVID-19 website, and it's exactly in the section where Doug Thurman has all of his information regarding the PUI form. So it's in that same, I hope you all have that website bookmarked, because that's your go-to for anything and everything COVID-19 infection prevention. So we have our COVID-19 provider link on there, and you know, it's a legal agreement between your hospital and the CDC, because you're receiving, it's a federal entity, it's an EUA product, so your CMO and your CEO have to sign for it. So a key point with a lot of the hospitals, the majority of your hospitals are already on KHI, or the Kentucky Health Information Exchange, which means that when you give doses, they'll be dumped into KHI, and KHI is connected to our registry. The difference with this vaccine is really, for the first time ever, every state immunization registry is going to be connected to a CDC software platform for ordering, tracking, and documenting. It's a system that we use normally called VTRAX, but it's actually going to be connected to this this Operation Warp Speed Department of Defense platform called Tiberius. So, you know, as much as the state and the country are trying to have clarity on the COVID-19 testing, we are also, for the first time ever, going to have real clarity on the COVID-19 vaccine, where it is, what the uptake is, how many people have taken it, what are the demographics of the people taking it. And so that's going to be something very different for our program and for immunization programs across the country. We know that the initial supplies are going to be limited. What's forecasted right now is 20 million doses of each, and being that Kentucky is 1.4% of the population, we get roughly 280,000, 300,000 doses. So critical healthcare employees are phase 1A. One of the things that hopefully everybody on this call has been invited within your institution, we did give charge to all members of the Kentucky Hospital Association to establish internal allocation committees, meaning that ACIP, or the Advisory Committee on Immunization Practices, they can say who should get this vaccine, but they can't really whittle it down to the granular level at, you know, Pikeville Hospital or ARH Hazard or St. E's or UK or U of L. When we have early limited doses, you all at the hospital level and at the IP level with your, you know, chief medical officer, chief nursing officer, really have to come together to further come up with allocation and stratification of populations within your healthcare group. So that's just not something that we can or that we really want to decide at the state level. So we've asked that you all do that. So until the ACIP guidelines come out, which will come out, you know, within days of the EUA, we're utilizing those NASEM guidelines. That's the National Academies of Sciences, Engineering, and Medicine. And those guidelines, I'll show I think my next slide shows a nice, this nice phase 1, 2, 3, and 4. I'm sure you all have seen this. If you haven't, it's a nice, I think it's an 84-page document that you could go through and read the whole thing one night when you're having some insomnia, but to all of us, it's probably pretty interesting. So based on these NASEM guidelines, we have established an allocation task force at the state, and then a separate committee with stakeholders with this group called HIMPACT. So HIMPACT stands for Health
and Medical Preparedness Advisory Committee. It's a group that's met before in kind of, tabletop type situations, well, this is what we would do if this happens. Well, this is what we would do if this happens. So now that it's happened, we've actually had to convene this group, and then from this group, we've established a smaller ad hoc committee of the HIMPAC, which will be meeting for the first time this Friday, where we will be ironing out, how we anticipate this equitable distribution, knowing wholeheartedly we do not plan to waiver or differentiate our state allocation from those NASEM guidelines and then from ACIP. We do plan to follow ACIP. What this committee will be doing more of is, well, how are we kind of going to get those doses equitably sent across the state? Although we know who they're going to, just how do we get those doses out there? And then beyond healthcare workers, once we get to the general population, the vaccine is free, and then HRSA is going to cover any administration fees for those who are uninsured. And right now, the federal government still is not covering the administration fee. They are allowing providers to bill for the administration fee because they do realize, of course, this is there is operational costs behind administering the vaccine. So these are the phases. We've got the high-risk healthcare workers and first responders in 1A, and this is the biggest. This phase 1A and 1B are the biggest lifts for every state. Phase 1A is where you all come in. Some of your hospitals may be stepping up as an open pod and deciding to immunize these first responders. And that's not just EMS paramedics. That's all first responders. That's your police, your fire, and some of our health departments are doing this. In other places, the health hospitals are doing this. So if you're a hospital that stepped up to help vaccinate your first responders in your plan, we appreciate you very much. But some of them will be doing it through their health department. And then as we go into phase 1B, this stage gets a little bit more complicated because when you look at our allocation in the state of Kentucky for this phase 1B, we have 5, it says people of all ages with comorbid underlying health conditions that put them at significantly higher risk, and then older adults. So the older adults are long-term care facilities and congregate care, and then you've got all this other catchment of obesity, diabetes, all of those comorbid conditions. So this is the really big lift here where we at the state are working to engage with pharmacies to really help with that, because most of those individuals, they go to their pharmacy to get their insulin or their hypertension medications, and so we're trying to partner with pharmacies for that. The older adults in the long-term care facilities, they are taken care of. I'm happy to say that 250 out of our 256 long-term care facilities in Kentucky have signed up for the federal program with CVS and Walgreens. So CVS and Walgreens are fully operationalizing this. It's a hands-off program for every long-term care facility, but it is just for the residents. We have asked the federal government to immunize the staff, and they can on a catch-up basis, but the long-term care facility workers are really considered part of this phase 1A here. They're considered a high-risk health worker working with those that elderly population in a congregate setting. So again, I would hope that some of your hospitals have stepped up and said, hey, as long as we're receiving that massive box of 975 doses, we're happy to also have our long-term care facility workers come get immunized at our hospital in addition to first responders. So for those of you who have chosen to do that, I thank you. For those of you who have not, we'll be engaging with health departments to help with that. So I jumped ahead a little bit, but that was the national partnership I was just talking about. And when I made this slide, we didn't yet have, KDPH will do a needs assessment. I'm so happy to report that our needs are really low, meaning that we only have 5 facilities across the state. And it was all the same national company who just decided to not enroll in that program. So they're taking care of it. And then the other big thing that I want you all to know is the phase 1 is Walgreens and CVS, and then for long-term care facilities. But in phase 2, once we hit phase 2, and if you remember and go back to phase 2 is huge. I mean, it's huge. It's a large, large population. But where phase 2 will become really a major, probably the largest major federal pharmacy partnership that we've ever had. The federal government has onboarded as providers all of these pharmacies. And this list here is actually not entirely comprehensive, because since this list was published, they are now, they have now added a group of pharmacies that are called PSAOs. So I don't know exactly what that stands for, but they are all your other kind of smaller mom and pop pharmacies on the corner. Right here in Lexington on Romney Road, I have Wheeler Pharmacy, and I know Wheeler Pharmacy is part of, I think, like Friendly Pharmacies. And so Friendly Pharmacies has signed on as a national provider. So pharmacists are really going to have a huge role in the phase 2 and beyond, but specifically in phase 2. And then once we get more doses, doctors' offices will be more involved. I wanted to review, these are the latest allocation FAQs that I have directly from the CDC that I thought some of you might have on this call. Children, nope, they're not going to be available because they're just now in the clinical trials. Again, how is it going to be allocated? I pretty much covered this, the critical populations. But then if you look at this too, current and local spread of prevalence of COVID-19, if we were to get some really, really limited doses, well, then our allocation committee might have to say, wow, we're going to go where the biggest morbidity, we're going to have to send doses to the places where we have the most morbidity and mortality. This is an important one. How will jurisdictions know if they're going to receive the same doses, and should they hold back for that second dose? And when the vaccine is limited, the federal government is going to hold the second dose. So if you are a Central Baptist entity hospital and you guys happen to receive the Pfizer product, you're going to give every single Pfizer product that you receive to every single healthcare worker that you can. You're not going to hold doses for their second dose. You will be guaranteed and entitled to a second shipment for that dose 3 weeks later. Then this might be a question that you all might have as well if you're going to be helping to operationalize this. What's going to come with the vaccine? Every 100 doses of vaccine will have needles, will have syringes, will have alcohol, will have masks, will have face shields, and will have little vaccination record cards. Paper postcards are great. You know, I would encourage people to tell people, you know, a piece of paper is great, it might get lost. I would encourage you to have people snap a photo of their reminder card and put it in their phone, since most people do have smartphones nowadays. One of the things, you guys are infection preventionists, you deal in sharps. So one of the things that does not come with these kitted containers is sharps. So you do, that's one of the few things you do have to provide is your own sharps. With the ultra cold, they're not sending special gloves with that, so whoever's receiving it in your pharmacies may have to use special gloves, but that could be changed. Again, cost, no one should be turned away for cost. You could bill an office visit or a clinic visit if they meet the requirements. And then this is another one that has been coming up a lot too, so the CDC put this in their FAQs. Will you be able to charge an administration fee? And yes, you can charge an administration fee. No one is to be turned away if they can't pay, and HRSA will provide reimbursement for uninsured patients. So I have some time left. I figured there may be questions. I did put on here, and I actually will, if this is live and I can click to it, let's see. Can you all actually see my screen?
Yes, we can.
Okay.
Oh, wait a minute. No, we're seeing your last slide. I apologize.
Okay, that's all right. It was a live link, but if you go on that live, that link there, you'll see where the provider, KY COVID provider enrollment is. There's a checklist. There is an algorithm. If you do this, do this. And then there's also, on the checklist, there's an email at the bottom that is KY COVID provider, vaccine provider, which is our help desk. So if you have specific questions about enrollments as a provider, you can email there. So I'm happy to take questions.
Thank you, Emily and Doug, of course. If anyone has questions, please feel free to place them in the chat box. We'll give you
of course, my oversight was, the Moderna vaccine. We're all crossing our fingers here that we get a nice big allocation of that one. It's a lot different than Moderna. It's, it comes in, you can order minimum doses of 100, so it's not that 975, and it doesn't have to be reconstituted. It's very similar to a polio vaccine. It's 10 doses per vial, and then they come in boxes of 10, so you've got 100 doses, and it's good in the refrigerator for up to 30 days, which is really nice. So that makes a big, not that we want to wait 30 days to immunize. This is a pandemic. We want to immunize everyone more quickly, but, and I have, when I clicked on my, let's see, maybe it'll let me enter again.
Hello?
Deb, when I clicked on my on-stream media thing, it kicked me out, but I think I can still hear. I just can't see.
Oh, okay. Sorry about that.
That's okay. So if you can read.
If there are any questions, I'll read them to you. If anything comes up on the screen, I'll read them to you. So I do not see any new questions in the chat. And I know that sometimes when there's this much information and also you will have the slides, you may think of questions afterwards. And if I don't know the answer from working with Emily on the task force, I will, or the committees, what are we calling ourselves? Task force, I guess. We'll, I'll be happy to pass that forward to the right person or send you the link that Emily has provided if you don't see it in your slides. Trying to give people a minute in case they're trying to type. Like, don't see anything right now. So Emily and Doug, thank you so very much for all of the answers to all of our questions. Obviously, that must have been really complete since we don't have questions on that. I know everybody's anxiously awaiting it. We don't have any more sense of time except soon, right, Emily?
No, contingency planning, possibly early to mid-December for the first doses, but the thing is, you all are going to know same time I do because, Moderna, Pfizer, they release things in the news and then the EUA goes out, so it's all such real time that as soon as you hear that, oh, Moderna submitted the EUA, okay, it's a matter of weeks now, so, yep.
Okay, perfect.
Thank you so much.
Thank you so much again.
Thank you.
Thank
We
you.
really appreciate you. Thank you so much. Appreciate your time.
All right.
Okay, we'll move on to our last speakers and our last topic. And so first of all, I want to say that Melanie is going to provide a link in the chat box for everyone on the call. If you're interested, they are asking you to to complete a survey using that link, and they will share the results with us. And also, you will be entered. I guess everyone will get will get a $5 Starbucks gift card. So the link is there now. I see it live in the chat. So if you'd like to click that link and do that survey and get a $5 gift card, you can do that. Plus, you will just be providing information to our speakers, which would be great. I know they'd appreciate that. So I'm going to read the bios for both of the speakers and then introduce our first speaker. So we have Bruce Rippey, who's the CEO at Trinity Guardian. He is a serial entrepreneur who was responsible for inventing Trinity Guardian's flagship product, a hospital bed barrier designed to prevent patient infections, and guiding the development and validation of this unique product. As CEO, he oversees all operations of the company. He previously served as CEO of Rom Weber and for more than 30 years was active in managing product development, including 20 years developing patient room products for Hillrom and MedMiser. Bruce holds a BSBA in accounting from Xavier University. Dr. Edmund Hooker is an epidemiologist and practicing physician in the emergency department at the University of Cincinnati Hospital and directs the clinical research coordinators program there. He also serves as the clinical advisor for Trinity Guardian. He earned his MD degree from Eastern Virginia Medical School and completed his residency training in emergency medicine at the University of Louisville. Welcome back, Dr. Hooker. He teaches health administration to undergraduate and graduate students at Xavier University, and he has authored more than 60 publications in leading journals and has an active research agenda in both emergency medicine, infection control, and health administration. And I think we're going to start this presentation with Dr. Hooker.
Well, thank you. And I also have a degree from UK, so I'm very conflicted at basketball season. So
I bet you are.
So I have a doctorate of public health from UK. So yes, we'll get started here. I think we can start this video. This is a video of the cover being taken off a bed and being inspected. If you didn't know, you can unzip these covers on most beds, and you can see the damage inside of these covers. The cover is stained, but then when you get inside, you can see blood that's gone through the cover, and that blood can go through and then come back onto the patient. And so this is something, when we're talking about inspecting a bed, you can't just look at it and say, oh, it looks okay. Oh, it just has a little bit of staining. When you open it up, you will not be happy with what you find, and you've got to realize that the patient's being put at risk. And you see that light shining through and show the severe damage. So that's a really good way to kind of start this talk. I think people don't realize the problems they've got with their mattress and bed frame, which we call the bed deck. So let's kind of go through this whole thing by the numbers. So most hospitals, the last time I asked at APIC, almost all the hospitals were doing a single-step process for cleaning and disinfection. That is against both the manufacturer's instructions for use and against the FDA recommendations. Number two, ECRI, if you know ECRI, it's a quality organization that does quality around the United States. They listed mattresses as their number 2 healthcare concern in 2019. Annually, we're having about 235,000 cases of C. diff, hospital onset C. diff, in the U.S. each year. If the previous patient had a healthcare acquired infection, the next patient is almost 6 times as likely to get a healthcare acquired infection. And if the previous patient had C. diff, you're 2 to 3 times more likely to get a C. diff infection. The bed barrier that we're going to discuss today has been shown to remove more than a 6-log reduction. Basically, the covers get completely clean. We couldn't find any bacteria on them, and we had put billions of C. diff spores and bacteria on there. 50% decrease in healthcare-acquired CDIs with the use of the bed barrier. Estimated savings over your current processes of doing that single step and renting your beds and getting it is you're going to save about $157,000 a year with a 40-bed ICU. And if you there's no increase by using ours, you're not going to increase your costs by having pressure ulcers. We don't get pressure ulcers by using the barrier. So I showed you the picture. This is just another picture of the staining that occurs when fluid soaks the mattress core. This occurs very often, more often than you know. If you're not opening your mattresses, you don't know how bad your problem really is. Just doing an exterior inspection will not identify these problems, and you will end up using your cover beyond its expected life. When the cover's bad and you have stuff inside the mattress, you have to replace your mattress. Sorry. There we go. So let's talk about a little bit of definition here. So we have, this is a hospital bed. The support surface or the bed deck is the metal frame that the mattress sits on and supports the mattress. And the topper is that polyvinyl, it used to be vinyl, now it's not anymore, but it's a topper made to try to prevent liquids from getting into the core. The core has a depreciable life and warranted for 5 years, some cases 10 years. The skin is only usually warranted for 1 year, okay? And that's a real problem because based on your disinfection cycles and what all of us are doing now where we're cleaning the living tar out of every bed, trying not to spread not only C. diff, but COVID and all sorts of other HAIs, we're going to destroy these mattress covers a lot, or toppers a lot quicker. So cleaning and disinfection is two different things. And anybody that's selling you a product that says they can do it in one step is not being honest with you. That is not allowed. Cleaning is one step according to the CDC, and then you must make a completely separate step to disinfect. You've got to remove all the organic and inorganic material first in cleaning, and disinfection inactivates any pathogens that are left over. So healthcare organizations often fail, 71%, to reduce infection risk from equipment, supplies, and stuff. This is the the Joint Commission talking here. They said that when they look at it, people are not doing a good enough job decreasing infection risks on reprocessed equipment. And I think when we hear the word reprocessed, we always think of the endoscopes, but your bed is being reprocessed for the next patient. That is in the same bucket as that endoscope or that endocavitary probe. So the term MIFU is the manufacturer's instructions for use, okay? This is what Hill-Rom, Stryker, and every other bed manufacturer, I'm not picking on anybody, all of them have their instructions for use. And based on those instructions for use, you're supposed to clean the bed or the endoscope or whatever it is according to that way to reprocess it. And CMS and Joint Commission say you have to follow those instructions for use. We're going to talk about those in a minute. Those instructions for use are very clear on what you need to be doing, and a lot of people are not doing it. So starting actually back in 2012, the FDA started receiving reports of of mattress failures, and by 2017 they had received 700 of them. This is where blood and body fluids had leaked back out of a mattress onto a patient, okay? So I think as a kind of a collective ooh, that makes me sick. I personally laid on a stretcher back years ago and had blood come out of the stretcher. I think we all have known about this. We've had reports in our hospitals. When I asked at APIC, almost 50% of people said that they had, in their hospital, had an experience with blood or body fluids coming back out onto the patient. So FDA said in 2017, You need to inspect your mattresses. You need to have a plan to inspect them, and you need to maintain the covers according to the MIFU. They did not define how often you need to inspect them, but the manufacturers did. We'll talk about that in a minute. So I mentioned this already. Most hospitals, 86% were using single step, one wipe and done, and just over 50% had experienced mattress failures and body fluid leakage onto a patient. So here's some lovely pictures of failed mattresses. These are real mattresses that were in service in acute care facilities here in the U.S., in the Midwest. And you can see the staining on the left. In the middle, you can see blood that has now soaked the mattress. And you can see inside the third picture on the right, you can see what's called the fire barrier. That is to prevent the person from getting burned to death if the fire occurs. That is completely shot and should be replaced. You can also see on that cover, it's disintegrating, the backside of the cover. So mattresses are difficult to disinfect. They are a soft surface. They've been a significant source of HAIs. I'm shocked the hospitals that are willing to report the people they killed with mattress-acquired HAIs. The French seem to be willing to report it. I think it occurs in this country all the time. It's just people aren't willing to report it because of the medical legal risk. But this particular example of an outbreak of Enterobacter cloacae, I always say that wrong, I apologize, but that one resulted in 4 deaths. When they replaced all the mattresses, they stopped the outbreak. So in 2019, showed a connection between sick patients and contaminated mattresses. Klebsiella sickened 19 patients, and they showed that it was all from one bed unit. All the mattresses were replaced, and they basically wiped out the problem. Mattresses, the big change is mattresses are soft, porous surfaces now, okay? If you look here on the right, that's an electron micrograph, and it shows you all the crevices that bacteria can hide in. Sorry. So fabrics changed. Used to be vinyl, like the car seat in your car, okay? Back in the 1950s and 60s and 70s, you had vinyl seats. We all stuck to them in the 80-degree weather. Now we have polyurethane and soft porous, and the reason is because we had bed sores. And because of the concern for that, we wanted to make the fabric more breathable. So the problem is that one-step process doesn't clean that polyurethane. Manual wiping is inconsistent at best, and there's multiple studies that looked at manual processes versus automated ones, and you just can't do a good job. And if you don't disinfect, you're not going to remove these multi-drug resistant organisms. And a lot of people will say, well, I've got this product and it says it has a log 1 or a log 2 reduction. That means if it's a log 2 reduction, it means it decreases it by 99%. But if you had 1 billion C. diff spores on the mattress, which you could, you still have 100 million spores sitting on that mattress, okay? Or even 10 million. That's a lot of spores. It only takes 7 to cause an infection. So you can't just say, oh, I can just kick it down and it won't be any big deal. No, we're going to kill people if we don't get these mattresses cleaner. So here's a picture of the old vinyl seat, and I've already kind of gone through that why we changed. But these new microfiber, vapor transmission fibers, they don't last like the old vinyl mattresses. They have if you look on the manufacturer's website or on their instructions for use, it'll say that they normally last 1 to 2 years now. That's all they're warrantying them. And I think you're not planning on replacing your mattresses that quickly, but you actually are going to have to. Sorry. So disinfectants do not, that's a typo, do not have efficacy on soft porous surfaces. If you pick up any bottle of cleaner, or excuse me, disinfectant in your hospital, I challenge you, go grab the box if it's a wipe, grab the cleaner bottle, and it'll say right on there, not intended for the use on soft porous surfaces, or it'll say only for use on hard non-porous surfaces. That's not a bed. So every chemical you got is actually not approved for use on these mattresses. UV light doesn't work. They have no registered claims with the EPA or the FDA at all for soft, non-porous surfaces. The way these things have all been tested in the lab is they put the bacteria on a hard metal plate and they irradiate it from a very short distance, and of course it doesn't do badly. But if you'd use it in a real room, it doesn't work. By the way, if you're saying, well, I'm going to culture my mattresses to see if they're infected, if you use swab, we did a study and we showed that the mattresses all had bacteria on them, but if you use swabs instead of Petri film or Rodak plates, you only identified the bacteria present only about half the time. AT meters, also that's a typo, do not work on soft non-porous surfaces, so please don't be using AT meters to decide that you're actually clean. So what happens to the mattress? Well, first of all, if you are doing like every hospital, you are using super harsh chemicals. A lot of you are using one-step processes and leaving these harsh Clorox or chlorine products or peracetic acid you're leaving on the mattress, which literally destroys the mattress. It literally absolutely eats it. And you can see here some evidence of damage, polyurethane damage with micro cracks. Well, those micro cracks very quickly become big cracks, and very soon, as soon as they're big cracks, blood and body fluids can pour in and out of that mattress and give patients both infections and other potential healthcare acquired conditions. So the other thing is as you clean, if you look on the left, that's a new mattress with the polyurethane layer here. This is adhesive, okay? Polyurethane, there's the adhesive, and fluid can't leak through. Great. Now look how thin it is. The polyurethane has been eaten down to almost nothing. The adhesive is almost totally gone, and this thing can leak like a sieve. So, it's interesting, the moisture vapor transmission fabrics have about a quarter of the life of other fabrics. They are much thinner. They're only about 1/40th of an inch thick. And when you expose them to repeated cycles, you basically destroy their waterproof properties. And so the outer cover is what protects the core from being destroyed. And so with the disinfection cycle, you go from what you thought was a 5-year time to have your bed to maybe 1 year, okay? So it's a huge problem. Those diagrams just show how quickly the moisture vapor transmission fabrics deteriorate. So, well, let's ask what the experts say, the CDC, the FDA, okay? So what are we first saying? The mattress cover helps prevent contamination with body fluids. Specifically in the CDC documents, it says linens are not considered a mattress cover or barrier. Do not assume that that gives the patient any protection, and it doesn't, okay? Bacteria, blood, viruses, all can go right through that. They recommend, CDC says, to use a disinfectant compatible with the mattress cover material. There are none, zero, none at all, that are compatible with soft, porous surfaces. That's a problem. The difference between cleaning and infection is not always understood according to CDC, and they're absolutely right. People think you can use this one-wipe system, which unfortunately doesn't work because you need to clean, and then you need to rinse, then you need to disinfect, and then you need to rinse again. We'll talk about the manufacturer's recommendations on that in a minute. So cleaning is one thing, that's 99.9%, okay, that's cleaning or sanitation. But when you're talking that you want something disinfectant, you need 99.9999% decrease, a log 6 reduction. You are not getting that with any of the things that you're doing currently. So you're supposed to pre-clean. If there's a big pile of poop on the bed, you're supposed to remove that. Then you're supposed to clean. Then you're supposed to disinfect. So you can't look at hard surface disinfectants and take any of their claims as being legitimate for the mattress, okay? So this just makes me want to stick this picture here that someone's duct taping together a mattress. You've got all this staining here. All the microorganisms can grow in there, no problem. So, so we already know the disinfectants don't work, but if you're going to use them, you also have to leave them on long enough. So now there's some disinfectants that say you only need a 3-minute contact time. Well, that's nice, but a lot of them are 10 minutes, and that means that surface has to stay wet for 10 minutes. You can't dry it off. That's how long the chemical has to sit there. That's based on those metal plates that they actually did the original testing with. They would put bacterial metal plate, flood it with disinfectant. Yeah, I'm sure that does work, but that's not what happens in the real world. You look at a mattress, I see mattresses all the time, and I watch someone wipe it off, clean it, maybe with multi-steps or just a single step, and guess what? That mattress is dry in 2 to 3 minutes and didn't work. You didn't actually give it the contact time that it needs it. The problem is these moisture vapor fabrics, transmission fabrics that help prevent the pressure ulcers, actually absorb this disinfectant. And then that's part of why it destroys it. So it's a huge problem, and we're destroying it, all of our mattresses. So you can cause the failure of the mattresses. You can see the polyurethane coating peeling here, scrapes from probably related to putting x-ray cassettes. This is striations. This is caused by chemical damage. These were, both of these mattresses were not sound and actually had fluids leaked inside of them. These are not pictures that we made up or found in online. These are actual failures in hospitals that were in use, beds that were in use. Have any of y'all seen any of your bed decks looking like this? First of all, I'm going to bet some of you have never looked at your bed deck. You got to look at it. That means you lift up the mattress and look. If you have rust, that bed needs to be brought out of service. That's according to the CMS. That's according to Joint Commission. That's according to your state health department. That kind of rust is a great place to grow bacteria. Bacteria just love rust. They think it's awesome, okay? So the disinfectants just absolutely eat the paint off of these beds. Then they rust. Cost you about up to $5,000, $3,000 to $5,000 to have this repaired. You can't just spray paint it. It actually has to be taken to a special company, sandblasted, and recoated. So also on the right, you can see the dried blood and body fluids on the metal bed deck. So guys, these bed decks are dirty, they're rusted, they've got to be cleaned and replaced or recoated. So the FDA kind of jumped into the fray. UV light keeps claiming they're going to save the world, and of course we know that it doesn't work. I think many of you would say that if you were the speaker today. First of all, let's just focus on the mattress. The FDA says UV light is not intended for soft porous surfaces. They just said that, okay? I'm not making this up. They said don't do it, okay? It doesn't work. Limited data about what UV light can do with SARS-CoV-2. Oh, have you heard anybody trying to claim they can fix SARS-CoV-2? I think I have. Inactivation of viruses on the surface may not occur because of blocking of UV radiation. Okay, guys, UV light is not going to work just based on simple physics, okay? If I put a UV light a centimeter away from a surface, which is how it's tested in the lab to get approved by the FDA, okay? If I do that, yes, I'm going to kill the bacteria on that surface, no question. But that's not how you use it. You've got that light in the room, and you've got surfaces that are up to 12 feet away. Everything that's more than 11.5 to 11.75 feet away isn't going to get any effect. That's why the UV light doesn't work. That's why you bought those things, you put them in your hospital, and guess what? You got no decrease in your healthcare acquired infection. Or if you did, it was short-lived. And the reason was because when you first put the thing in, you were cleaning a lot better, and it was the cleaning a lot better that actually worked. So basically, the FDA said there really is nothing we can say that this works. on hospital beds and mattresses. And if you look on the right here, you know, you've got to remember that if you've got a damaged mattress, nothing's going to work on it, okay? And UV light actually may damage the mattress even worse because it causes plasticizing. So if you're close enough to the UV light, you may actually damage the mattress. And none of the mattress manufacturers actually recommend UV light to disinfect a mattress. It is not part of a single mattress manufacturer's instructions for use. Regulatory agencies said hospital mattresses are a significant source of hospital-acquired infections. That's also ECRI. There's a difference between cleaning and disinfection. They are totally different steps. Cleaning is removal of gross organic and inorganic material. Disinfection is killing any residual bacteria. Mattresses are difficult to disinfect because one-step processes don't work, and hard surfaces are what those chemicals were for. And please, if you're going to use UV light, make sure you understand what the manufacturer of that bed mattress tells you whether it is compatible or not. So this is just a picture of clean mattresses. These are ones that were clean, disinfected, terminally clean, ready for next patient, and you can see there all the trapped skin cells, all the garbage up here. So if you look, most of these mattresses have a zipper, and they've got a flap, and under that flap you can accumulate all sorts of nastiness, blood and all sorts of garbage. Just so you know, also, that zipper has about 3,000 microscopic holes that stuff can go into the mattress. Okay, so the zipper is shown around 3,000 holes, and you can see here the leakage through those zipper seams, okay? Leakage of blood and body fluid. So it's interesting. We use the thing, GlowGerm's kind of interesting. You can put this on a bed if you're interested. You can buy it, and then you use a UV light to basically, or black light to look at it. But it shows that you can't get all that stuff off. You clean it, and yet the GlowGerm, and GlowGerm has been shown to stimulate bacteria very well. It's all down in that fabric, okay? So cleaning it is not cleaning, okay? What you think you're doing now, what EVS is in there for, unfortunately, only about 30 minutes, isn't going to do the job. All right, and what the problem is that if we've actually done some time studies, it takes about an hour just to clean the bed and mattress. And most EVS workers are given 30 minutes to clean the entire room, including the toilet. This is a picture of somebody cleaning the bed, and after they cleaned it, you can see the GlowGerm lighting up where there still is residual dirt. Okay, I can get it. There we go. So, interestingly, in 2015, the FDA said, you know what, we want all manufacturers to revise their manufacturer's instructions for use to make sure that they can clean their product. This had to do with all the stuff with the endoscopes and everything. They're like, hey, beds are being reprocessed. They have to be reprocessed correctly. Okay, so every manufacturer is supposed to come up with it. This is an example from one of the major manufacturers of hospital mattresses and beds, and this is all the steps that they require. Pre-clean, remove visible soil, clean non-visible soil, and then rinse. Then disinfect and rinse again. And then clean the bed deck and rinse it. And then inspect it. Oh my gosh, this is almost nobody in the United States is doing this, and yet, if you check your manufacturer instructions of use, oh, by the way, you better find the one since 2015 that they had to modify, because the old ones were a one-step process. And if you go on the internet and look it up, you'll find a bunch of old ones with one-step processes. You need one newer than 2015 because they had to update it for every bed out there. So again, you're supposed to be using a multi-step process every single time you reprocess a bed for the next patient. So bacteria shed onto the mattress, unbelievable. Study just published this year. 44% of patients who were infected with an MDRO shed those organizations into their environment during patient care activities. And most of those patient care activities are done on the bed, okay? So these beds have tons of bacteria and viruses on them. And then Chen showed last year that most patients with MDROs also contaminate the environment. So if you got a patient, and we all have lots of patients with these MDROs, they are going to shed this stuff into their environment and cause a big problem. So I did a study in 2012 where we looked at reprocessed mattresses, ready to go, bed decks and mattresses, and we found 83% of the mattresses, after they had been completely cleaned, ready to go. We told the EVS, we're coming behind you, make sure you do it well, so that they did the best job possible, and we found bacteria on 83% of the mattresses, and oh my goodness, let's look right there. There's a lot of MDROs on there. So this is a really big problem with HAIs being caused by all the ones in blue. You've got to clean better. We've got to do a better job. So it doesn't meet the FDA guidance. It doesn't meet the CMS's guidance because you're supposed to follow the MIFU, and it does not work. I showed in a study where after the patient's discharge, before before terminal cleaning, it was 79 CFUs, and then after terminal cleaning, it still had 13 CFUs. And interestingly, the bed deck was worse, and I think anybody listening to this talk knows what's going on there because they watch these EVS workers unfortunately clean the top with one rag, clean the whole mattress, and then clean the bed deck. And so it's like spreading peanut butter. They grab all the bacteria from the surface of the mattress, and by the time they get to the bed deck, they've got a viral and bacterial delivery rag is what they've got. So again, commonly used reprocessing practices are not compliant with FDA, not compliant with the MIFUs from the manufacturer, not compliant with CMS. So disinfectants used are causing mattress failure and bed frame damage. Mattresses, you need to verify with your mattress manufacturer validated cleaning and disinfection steps. Don't let this manufacturer give you a bunch of boohooey. Tell them, I want this since 2015 MIFU, and then you've got to follow it. You have to follow it by Joint Commission and CMS rules. Peer-reviewed study showing reusable launderable barrier is more effective at eliminating bacteria and decreasing HAIs. So again, Bruce, are you going to take over at this point?
I can.
Why don't you take over?
Okay.
They're getting tired of hearing my voice.
So thanks, Eddie. The bed barrier interventions have been proven in several...
Bruce, sorry to interrupt you. Could you talk a little bit louder? I'm having difficulty hearing. I bet others are too.
Okay. Is that better?
Yes, sir.
Okay. So our bed barrier intervention's been used in several different studies to prove that it can reduce hospital-acquired infections. And it does that by protecting the patient from what's on the mattress and the bed frame. It's fluid-proof. It has no sewn seams. The whole cover is welded together, which is basically, the concept would be like melting the plastic together to make it fluid-proof. The design of the cover is such that fluids cannot get from the patient to the underneath side of the mattress and the bed deck. And why that's a big deal is because as EVS workers try to address a bed deck, they can pick up the bacteria, the residual bacteria on the bed deck, and then spread it around the room. And we've had a couple situations with customers where they've had outbreaks in their bone marrow transplant unit that were traced back to the bed frame itself, not just the mattress. Our product can be laundered with bleach and at 160 degrees. It's also dried at 160 degrees. And our laundry process is kind of a belt and suspenders approach in the sense that not only are we using high dosages of chlorine, but we're using high heat in both the laundry and the drying process. The product itself is made of a breathable polyurethane. The patient won't realize they're on it. It's made of a 4-way stretch fabric. Dr. Hooker talked initially about the fact that our cover has been proven not to increase pressure ulcers as a result of its use. That's actually now been proven in 2 peer-reviewed studies. And the cover design itself has been such that whatever the bed does in terms of functionality, our cover does as well, while protecting the bed frame, whether it's a turn assist or a extension of the bed deck itself. These are some of the studies that Dr. Hooker had mentioned before, where we've reduced hospital-acquired C. diff. This was done in 2 LTACs here in Indiana, and I believe both of these studies were about a 45,000 patient day study. Both of them had about a 50% reduction in hospital-acquired C. diff. This was published in AJIC back in 2015. This was published just this past year in another healthcare journal. This was actually a Bon Secours hospital in Kentucky that had a 59% reduction in hospital-acquired C. diff as a result of using the product. And here is the study data corroborating that there was no increase in hospital-acquired pressure injuries. We've also just recently finished a major laundry study. This validates the laundry process, where we've inoculated the cover with over 1 million viable C. diff spores. There were none left after the laundry process. We've also applied a serum of various other MDROs on this cover, and we had a 99.9999% reduction in C. diff and other pathogens. And this is at the end of the life of the product. And as Dr. Hooker alluded to, and it's really an important point, with the new FDA guidance, manufacturers now have to state the expected life of every medical device, whether it's an endoscope or a mattress cover. It makes no difference. The manufacturers now must state that. And if you read the ECRI guidance document as well as the FDA safety advisory, they both speak to that. That's really an important point, because when you get to the expected life on a piece of fabric, or get to the end of the expected life of a piece of fabric, it makes cleaning and disinfection even more difficult, and considering the fact that we're using products off-label, it makes the fabric fail even faster than the expected life if you don't follow the instructions for use, which is why the FDA is really encouraging users to follow the instructions for use. This is a picture of the cover after it's been laundered. This was done by a major microbiology lab in Cincinnati. And this, I think, is really important information for you all to realize as well. So right now, we just finished a major audit of about 700 beds at a major hospital system, university system, and they were using a 1-step process to clean and disinfect. They were using bleach. They did not rinse it off. And we looked at the mattresses, the mattress covers, the bed decks. We opened up the mattresses. We looked for holes, tears, bodily fluids, and we looked at the replacement criteria based on the FDA recommendation. Here's the results. 727 mattresses were inspected. 183 of those had failed, 25%, meaning there was evidence of fluid inside the mattress. There has been a number of studies that have come out on this over the years. The numbers are very similar. What is interesting about this study is we were able to use the place in service date from the law label on the mattress, and many of the mattresses had failed at the 3-year mark, which goes back to the point of the expected life of the fabric. the important takeaway for you all here is the fact that the CMS is reimbursing you for these covers at the rate of about over a 5-year period. So if the cover and the mattress lasts less than 5 years, it's just an added expense to the hospital. 45% of the covers had failed. Now that's over and above the failed mattress itself. So what we're looking at now is just saying there were puncture marks, staining, the type of damage that had not seeped into the mattress core itself. And that was half of them. So the total damage between the failed cover and the mattresses was 71%. 24% of the bed decks had rust on them. And again, that's a CMS violation as well as a local health department violation because of the disinfection challenges that creates for rust. We talked about how our product is designed. Some of the elements of our laundry process is that after each laundry, it's inspected on a light table, and if it is been punctured, we can use a heat seal to put a patch on it. And because it's laundered, we don't have to worry about disinfection around the patch because of the process this is going through. This also has an RFID chip in the cover itself that is specific to that particular product. And so there's full traceability as far as when the cover was used, when it was laundered, when it was removed, and who inspected it, so on and so forth. So it's a complete end-to-end process. The product is available for all different types of beds and mattresses, whether it's ICU birthing beds or just general med-surg beds. This next slide is important whether you're considering looking at this type of product or not, because it really goes to the point about what your true costs are. And so if you look at reprocessing today for the status quo for a 200-bed hospital with 18,000 discharges a year, the hospital will have about a $2.8 million investment in their beds and mattresses. That's probably about the 5th highest investment that the hospital will make in medical equipment. And when you look at the cost of reprocessing using a single-step process, including the cost of a disinfectant and looking at a rate of about 20% of the rooms needing a second cleaning process because they are isolation rooms, that reprocessing cost, including labor and the materials, is approximately $81,000 a year. But as a result of that one-step process, based on the data that I just presented to you from the 700-bed study, the premature replacement of those mattresses and the cost of the amortization of the mattresses that's on it will cost the hospital $173,000 a year. So there's a significant bump in the cost associated with not following the instructions for use when you look at the rate of accelerated failure that happens to your mattresses as well as to the bed frame. You'll also see that it also accelerates the cost of the replacement mattress skin. Keep in mind that these fabrics on all of these mattresses are absorbing moisture from the patient. And as they absorb moisture, it's a polyurethane, they are very fragile, and it will take 24 hours for that fabric to completely dry. Well, if you're in a high acuity area or you're in COVID times and you have patient after patient on these beds, those mattresses are never going to thoroughly dry. And as a result, they're going to be far more susceptible to damage, which can lead to the mattress leaking fluids inside the core of it. And some of these mattresses, as you may well know, are in the range of $3,000 to $7,000. There's some today that go all the way up to $20,000. And as a result of that, if you're not inspecting mattresses, the cost of those mattresses and the failed skin becomes even more because you don't know that the skin has failed and that the fluids are leaking inside. So this schedule is really just outlining what the true cost of status quo is. I think a lot of hospitals might think that they're saving money by going to a one-step process, but the fact of the matter is if you look at the higher instances of failure, if you really knew what was going on with the equipment as a result of the misuse of the disinfectant, you would see that the total cost really is higher than you would think. And the reality of it is actually higher than the MIFU cost, even though the MIFU cost will have you doing 6 individual steps to meet the FDA guidance. So these are certainly very real costs. And then there's the cost of inspection. And depending on which manufacturer you're using today, every mattress manufacturer in their instructions for use requires interior mattress inspections. That has to be valid. That has to be documented for CMS and Joint Commission inspections. And the problem with that is they are very time-consuming to do, because if you have a high census in your hospital, you may not have the ability to inspect a lot of mattresses in a day. Typically, you would only be able to do 8 to 10 a day with one inspector, because they have to follow environmental services and inspect after a room's been discharged. And so it becomes a real challenge to do that, and then mattresses and beds move around the building and they got to go find them. It can become a real struggle for the person doing this. So these inspections are very costly as well. And then there's the cost of C. diff. And so what we've done in this model is to demonstrate what the true cost of C. diff is. And in this hospital example, we used an average rate of about 6 per 10,000 patient days. And as a result of that, their cost would be approximately $712,000 based on a national average of $15,000 per infection with a 10% readmission rate. Based on the success that our product has had in reducing CDIs, we believe that there is an opportunity to reduce those costs by almost half. And we put that in this model to demonstrate what the total impact of this could be. Most hospital CFOs do not want to look at infection reduction as part of a payback model. So this just represents the hard and soft cost. The previous slide represents just the hard cost savings, which is about $130,000 a year in using our product. The lifetime savings over the life of our product is $340,000. That is all in, including the cost of our product. So there's a real cost benefit, as well as the ability to have a compliant cleaning and disinfection process for your beds and mattresses that's been validated, that meets all the Joint Commission and CMS requirements. So it's a way to extend the life of your bed and your mattress, as well as to cut your labor cost when compared to the instructions for use. And as hospitals move to more and more expensive beds to keep up with the technology and the communication opportunities there are within the bed now to Bluetooth devices, this is really a big deal. The other point about all this is hospitals that are either short-term critical access hospitals or cancer hospitals can actually be reimbursed for using the covers because they're exempt facilities. And so there's some opportunities for reimbursement from that standpoint relative to the use of this product. But again, a big takeaway for everyone to understand today is that with CMS reimbursements, hospitals are reimbursed today based on their daily room charge that would include the capital cost of the amortization of that bed. And CMS is relying on the American Hospital Association depreciation table for a mattress. That's 5 years. If you get 2 years or 3 years out of it, that's the hospital's problem. And if there is no replacement cost reimbursement factored into the depreciation schedules for that mattress skin. And as Dr. Hooker said, some of those mattress skins can actually be damaged within a year. Some of them have an expected life of a year. And so when you're buying beds, it's really important to understand what the expected life of those outer skins are, because that's a cost you're not going to be reimbursed for, and it's going to become very costly because they will be impossible to disinfect once they start to degrade through use over a period of time. So my takeaways for you today is that extending the life of your mattresses has a profound impact on hospital budgets for the reasons that we talked about. Everyone obviously knows this. It's on this call that reducing HAIs increases patient safety in the bottom line. And we are here to help because our product will do both in terms of reducing your operational costs through a compliant process that provides a cleaner surface for the patient, as well as extending the life of the bed and the mattress and reducing hospital-acquired infections in the process. And with that, we'll be glad to entertain any questions you all might have.
Bruce, let me add one more thing that just that study you talked about with the 700-bed hospital or 700-bed hospital system. That is very much in line, and you mentioned that Bradbury out of, I think it was out of Boston, showed that a quarter of their beds had failed. But I think what's important is if you look at the Canadian study that had 2,500 beds, they were up at 33% failure, and it has to do with the age of the beds. And if your beds are 5 years old, which I'll bet you a lot of people in Kentucky have beds that are 5 years and 6 years and 8 years old, I'll bet you the failure rate's going to be in the 50% range. So I think everybody needs to go check their beds and their mattresses and their bed frames. They may be unpleasantly surprised, but I don't think any of us ever want to put patients at risk. So if anybody has a question, they can type it in the chat. We can always answer it.
Thank you very much, both of you. We appreciate it. I am watching the chat box. I don't see anything right now. I just want to say I had that very experience with the, I had a nurse call me when I was PICU manager at the Children's Hospital here and say, come look at this. And she pressed down on the sheet that was covering a bed that was ready for a patient. And blood and other things seeped up through the sheet. So I assume I'm not the only one that's happened for, but it did. And I have told a couple of people that and totally grossed them out and made them want to stay very healthy and never go to the hospital. So
absolutely,
it's great to have a solution to this, because that thing that you think about is that's one that was visible, but what do we not see and what do we not know unless we look? So very valuable information. Any questions from the audience? I got a thank you in the chat box. Thank you for the information from Mary.
I would just tell anybody that would like the actual original research, they're like, hey, I don't believe that, or I want to see that, delighted, they can contact me at hookere@xavier.edu, HOOKERE@xavier.edu. Delighted to send you any of them if you need them to help convince people in your hospital of it.
That would be great, and I would like to have it, quite honestly, so that if someone asks me a question, I have it handy. That would be great.
We can certainly provide that to you. Bruce, I think we put together a nice thing that's got all the references.
Right.
We can share it with you.
Great, great. Well, thank you so much. I don't see any questions right now. If people come up with questions later, I know how to reach you. So we appreciate your time and the information. And I will ask Melanie, if you're on here, could you let the group know anything you need them to know as far as CEs? And then I guess the survey link is still live if people want to continue to click on the survey and complete that.
Great, thanks, Deb. Yes, for your continuing education credits, we will be sending a Survey Monkey for you to do your survey results and also put your information in there, including your license number. You will receive that by the end of today, along with a copy of the slides, so that if anyone had any trouble downloading the slides today, we're going to put a PDF version in the email that you will receive today. That survey for your continuing education credits will be open for 1 month from today, so it will close on Friday, December 18th at 5 p.m. Eastern Standard Time. Please make sure that you do complete that in order to get your continuing education certificate. At this time, we'll take any last-minute questions in the chat box, or I'm going to unmute all lines at this point too.